Good afternoon, and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, welcome you all to the webinar today on Critical Care in Obstetrics, Reducing Maternal Mortality, organized by Maulana Azad Medical College, New Delhi, RCOG, North India, and NARCHI Delhi, with multidisciplinary national and international faculty with academic partner Jagsonpal Pharmaceuticals Ltd, makers of LycoRed Preg sachets containing L-arginine, lycopene, and DHA to prevent pregnancy-related complications. We also present Injection Maintain, 500 and 250 mg depot 17 alpha-hydroxyprogesterone caproate to maintain normal pregnancy till the term, and EndoReg, 2 mg tablets of Dynagest for the medical management of endometriosis and endometriosis-associated pelvic pain. A warm and hearty welcome to all the esteemed speakers, experts, and attendees. Dear attendees, we request you to post your queries by the text in the Q&A box. Please note this webinar is streaming live on the Facebook, and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. Now, we request the organizing chairperson of the program, Dr. Asmita M. Rathod, Director, Professor, and HOD of Obs and Gyn Department at Maulana Azad Medical College, to kindly take the proceedings further. Over to you, ma'am.
Yeah. Thank you, Ankit and Team Jagsonpal. It's a very warm welcome to this CME on a very, very important topic, that is critical care obstetrics. And I, at the outset, thank Dr. Ranjana Sharma, Chairperson, North Zone of AICC RCOG, for giving Maulana Azad Medical College this opportunity to host this particular webinar. Dr. Ranjana really doesn't need any introduction, as all of us know her very well. She's a chairperson of a North Zone AICC RCOG and senior consultant at Apollo Hospital. And without wasting much time, over to you, Dr. Ranjana, for the welcome address.
So, okay. Thank you very much, Asmita, for the kind words. And thank you very much, you and the whole team of Maulana Azad, for working tirelessly to bring this webinar to this level. And I know how much hard work has gone into it. And I welcome all the delegates to this webinar that is fully loaded with academic content and amazing faculty. I'm grateful to all the faculty, national and international, to be part of this activity. Their immense knowledge and expertise will surely benefit each one of us in achieving our goal, and the goal is reducing maternal mortality, morbidity and mortality. And this theme is chosen after much deliberation and considering the need of the hour in India, right? So thank you very much for giving me this opportunity to join your team and have this collaborative effort. So without wasting any more time, I invite the scientific session to start. Thank you.
Thank you very much, Dr. Ranjana. Now, I would like to just briefly introduce my organizing team, especially the organizing secretary, who have really taken a lot of efforts to organize this program. Dr. Deepti Goswami is a Director Professor of Obs and Gynae at Maulana Azad Medical College. And Dr. Nalini Bala Pandey is a Chief Medical Officer, and she is the DNB in emergency medicine, which is a very, very important asset to us in the department when we talk of caring for a critically ill woman. Caring for a critically ill woman is a very, very important component of our efforts to reduce the maternal mortality. And without wasting much time, I hand over to Dr. Deepti and Dr. Nalini to start the scientific proceedings. Over to you, Dr. Deepti, Dr. Nalini.
Thank you, ma'am. At the outset, I welcome all the delegates and our esteemed faculty and the chairpersons. And to begin with, I will show a couple of slides to put the perspective of this program in front of you. This was a study that we did at our department, myself along with Dr. Rathod and our colleagues, where we reviewed maternal death of 300 cases, in 300 cases at our center alone over a period of 5 years. And we deliberated on the causes of maternal deaths, and what came across was not really surprising. Hemorrhage, sepsis, hypertension, thromboembolism, and then among the indirect causes, hepatitis formed a big chunk, heart disease, the rheumatic heart disease, peripartum cardiomyopathy. So this is what helped me design this program. So various speakers, eminent faculty in their own rights, will be throwing light on these issues, and they will really guide us on how to tackle a patient, how to manage a patient who is critically sick with these conditions. So with these words, I begin to proceed to the first session of this program, and I will call upon our chairpersons. Our chairpersons for the first section, which will be focusing on the fluid therapy and oxygen therapy, Dr. Gauri Gandhi. Dr. Gauri Gandhi doesn't need any introduction to at least all of us. Ma'am is a much beloved, very much loved faculty, senior person from our department. She has been there with us, and we are very fortunate to have with us in this very important session. The next, after Dr. Gauri Gandhi, we have another eminent personality, Dr. Kamal Gujral. Ma'am, again, we all look forward to every word that she says in any platform. She is chairperson, Institute of Obs-Gynae, Sir Gangaram Hospital, and she has got so many important posts she has held. The third chairperson is Dr. Sohani Verma. She is a senior consultant Obs-Gynae at Apollo Hospital, and she has also held many important positions in the past. And now I request the persons to take over. Dr. Gauri Gandhi, please.
Thank you, Deepti, for this kind introduction. And yes, it is a very loving family at MAMC. And it's a pleasure to be here to chair such eminent speakers and to be co-chairpersons with such eminent teachers. So my pleasure to invite Dr. Rekha Bharti. She's a professor at Safdarjung Hospital and the MAMC. She has been recently editor in the AOGD tenure, which they had last year, very successful tenure under Dr. Achila Batra. She has had many other credits to her. She's member AOGD Endometriosis, FOGC, HIV Committee, past editor of NARCHI Bulletin, past co-editor AOGD, many publications. I won't read out the whole list, but she obviously has a very illustrious background. So I would invite her to speak on a very important topic of oxygen and fluid. Which part is Rekha speaking on? I think the oxygen therapy, is it?
Yes, ma'am.
Yes, so it's extremely vital. And after COVID, we've all become a little aware of this topic, especially because of all the problems with oxygen during COVID. So I welcome you to please go ahead with your speech. Thank you.
Thank you, ma'am. And I would like to thank the organizing committee for giving me this opportunity. And special thanks to my mentors who are here, Dr. Pratima Mittal and Dr. Jyotsna Suri. And, you know, whatever I have learned in the critical care is basically by their, forcing me into this. And the talk which I'm going to give is on the oxygen therapy. So this, although this is something which all of us are using day in and out, oxygen, but now there is a different terminology which we use for giving oxygen. It is, not a random thing that any patient who comes and you just start oxygen. So like any other drug, this oxygen also needs to be given in a certain prescribed form. So that is why we use this term oxygen therapy. So coming on to, the objectives of this session. So we should all be very aware of the indications of oxygen therapy. It should not be given randomly to any patient who is just admitted. And then we should, when we are giving oxygen, we should define our goals, that what we are trying to achieve. And then we have various oxygen delivery devices, which basically I'm going to discuss in this thing, because we all have been using these devices, but we have to have a proper knowledge of when to use which kind of device, and we should know that which kind of device is going to deliver how much of the fraction of inspired oxygen. And then why we say we should limit the use of oxygen is because of the complications which can be associated with oxygen therapy. Now, these are certain commonly used terminologies, like we say fraction of inspired oxygen. So this is basically the fraction of oxygen which is there in the inspired air. So normally room air which we are inspiring, it has 20 to 21% fraction of the oxygen. SpO2, we all have been using it for monitoring. So this is basically oxygen saturation. So it means that how much percentage of oxygen is carrying in the blood, which is compared to the maximum oxygen carrying capacity of the blood. So if we take it as 100%, 95% means that whatever hemoglobin is there, and out of which how much is, saturated with oxygen. Then partial pressure of oxygen. So this is, basically the pressure of oxygen in the dissolved blood. So this we measure by only arterial blood gas analysis. Now, coming to the indications of oxygen therapy, as we all know, first thing we want to achieve by giving oxygen is improve oxygen saturation. And another very important thing is at times we do give oxygen when the saturation is normal, just to reduce the work of breathing. So whenever we are giving oxygen, as I said, we should set up our goals. So what are our goals basically? So basically why we are giving oxygen is, what it can do is it will increase the alveolar oxygen tension. So this will decrease the work of breathing and also decrease the myocardial work. So basically we want to achieve PaO2 of more than or equal to 70 millimeter of mercury. And if we talk in terms of our, oxygen saturation, it should be more than equal to 90%. But when we are talking about pregnant women, it should be more than and equal to 95%, because as obstetrician, we all know this is what is required for the baby. So the guiding principle when you are giving oxygen is that you should give minimum therapeutic dose, because there are certain complications which are associated with oxygen, and they can be associated with, as low oxygen as we can think with 40% FiO2 can, this thing can also be associated with complications. So it should be minimum therapeutic dose, whatever patient needs. Then our prescription should be either in percentage or in FiO2. So this is very important. Then whenever we are giving oxygen, we should assess certain parameters. So there are bedside parameters which are available, which tell us about the well-being of the patient. So along with this, I'll be talking about the specific parameters which we'll use for the monitoring of these oxygen saturation. So this is, a type of form which is there, and this card should be attached. I think it is high time that we all should start using this kind of a card. So whenever we are giving oxygen, as we write for any other prescription for any other medicine, so it should be in this kind of a prescription form that you write the details of the patient. This is your choice whether you take them above on the top, or you can write it on below it also. Then the date and oxygen. So now here oxygen can be written as like you are giving oxygen. So you have to choose the target saturation. As I said, in pregnant patient, our target is more than 95%. And if the patient is not pregnant, and if she is, has some basic baseline lung pathology, then you can keep a target of 88 to 92% in non-pregnant patients. So this is the saturation which we are planning to obtain. Then whether you want to give it as pro re nata, which is SOS, or continuous, so this also should be circled. Then the device which you should be using, so that has to be written. And I'll just tell you in further presentation that why we choose a particular kind of device. And then, like, every time you are doing this, you have to write the saturation of the patient which is there, which you have obtained. So this is what a prescription should look like. And there are, certain abbreviations which are being given on the top of it, that if you are maintaining patient on room air, you can use RAN for nasal cannula. And similarly for other devices also, you can have various abbreviations used, so that you don't have to write complete this thing, because the space may be less. Now, if we talk about the oxygen delivery equipment, there are two kinds of oxygen delivery equipment. One are the variable performance. They're also called low flow system. And one are the fixed performance, which are also known as high flow system. So here, this is actually, if you just read it, you will feel that in low flow, you are giving oxygen at a low rate, and in high flow, it is being given at a high rate, but it is not so. It is basically the performance. So whatever you are giving, the same, the saturation is going to be delivered to the patient. Whereas in variable performance low flow system, it will also depend upon the patient profile. So this will, what equipment you're going to use will depend upon various factors, how much hypoxemia patient has, and what is requirement for the precision of delivery. As I said, if the patient has COPD, you have to be very precise in delivering the oxygen, comfort of the patient, and the cost. So these are the factors which we generally keep into consideration. Then low flow system, because it depends upon the patient, it is patient dependent. So the tidal volume, if it is less than 300, you should not use the low flow system. Respiratory rate more than 25, it is better not to go for low flow system. Then ventilatory pattern has to be regular and consistent. Patient should not have any problem with the ventilation. So if we see this, as I told you, it is not, synonymous with the low concentration of oxygen. So most frequently used low flow oxygen delivery system which we use is the nasal cannula. So we all have used it in our practice, and we know that we can deliver the oxygen flow rate of as low as 0.5 liters. So this is, basic advantage of using nasal cannula, and we can give up to 6 liters of oxygen with the nasal cannula. And if we talk in terms of FiO2, it will deliver 0.22 to 0.40 of FiO2 by giving 0.5 to 6 liters of oxygen. If you give a flow of more than 6 liters, one is that you will be wasting your oxygen because your reservoir size is very small. It is only 50 ml. So by increasing the flow of the oxygen, you will not be able to achieve higher FiO2. And secondly, it will also cause nasal discomfort, dryness, crusting to the patient. So one more important thing when you are using nasal cannula is that if you are giving oxygen to more than 4 liters per minute, then it should be humidified. So between 4 to 6 also, if you are giving, it should be humidified. So generally we use 0.5 to 4 liters when we are using nasal cannula. The only requirement for using nasal cannula is, one is the various parameters about the patient which I talked about, that the tidal volume should be normal, the respiration should be normal, ventilatory pattern should be normal. So if the passage is not patent, so what we mean by passage not being patent is if patient has nasal polyps and all. So there also it should not be given. But if a patient is mouth breather, you can still give nasal cannula to the patient. So now we all have used this, so we know how it looks like. So this is what a nasal cannula is. And if you see where it is going to deliver oxygen is in the nasopharynx. So when you are giving oxygen by nasal cannula, this 50 ml of nasopharynx is the reservoir. So only this 50 ml is going to be 100% oxygen. Rest oxygen is going to be delivered when patient is inhaling directly from the supply. And because the tidal volume is more than 300 ml, other part is going to come from the room air. So it is never 100% oxygen which is delivered. So if we generally just by definition, like if you just roughly want to calculate FiO2, for every 1 liter of oxygen per minute we are increasing the FiO2 by 0.04. So that means that normally we take it as 0.20. So if you are giving 1 liter, you are giving 0.24 FiO2 or 24% FiO2. So roughly we are increasing the oxygen concentration of the oxygen in the inspired air by 4% for every 1 liter. So that is how, you can also calculate this. Then the main advantage of nasal cannula is that patient is very comfortable, patient can talk, patient can eat also. And then next thing is that there are certain disadvantages also. There are few patients who do not tolerate nasal cannula because of the irritation. It may be because of the air, which is oxygen, which is being delivered, or it may be because of the chemical component of the cannula. And second thing, it is a variable performance. So performance varies with the patient's breathing pattern. The next important thing is that which we use is a simple face mask. Now, simple face mask, one very important thing which we have also learned and which we emphasize to all is that when you are using simple face mask, never keep the flow rate to less than 5 liters per minute. Because if you keep the flow rates to less than 5 liters per minute, the exhaled air will accumulate in the mask. So you need constant flushing of the mask. So to have that flushing of the mask, the minimum rate of the oxygen flow should be 5 liters per minute. And the reservoir will depend upon actually the size of the mask which we will take. It will depend upon the patient. So small size mask generally have 100 ml of reservoir. And if it is a large size mask, it is 200 ml reservoir size. So this is, something which is very important when we are taking this, that flow rate, you have to take more than 5 liter per minute. Then another thing is that if you increase the flow rate to more than 8 liter per minute, then also because the reservoir size you are not increasing, so you will be wasting the oxygen. So if you want to give for more than at the rate of more than 8 liter per minute, then you should increase the size of reservoir. That means we should shift to the further devices, which I'll be discussing in further in this lecture. So disadvantages are the same. In addition to variable FiO2, which will be delivered, which will depend upon the patient's ventilatory pattern, it has to be removed for eating or drinking. So if you are giving at 5 liters per minute, you are roughly giving around 0.40 FiO2 or 40%. And if you reach 8 liters, you are giving 60% of the oxygen you are giving. FiO2 is 0.60. So if you further want to increase the FiO2, if your patient's oxygen saturation is not being maintained on this, then further you have to increase the size of reservoir. So what will we be using is either partial rebreather type of mask with reservoir bag or non-rebreather types of mask. The reservoir basically is non-rebreathable type of thing. So I'll just show you all these masks with the reservoir which are available. The capacity of the reservoir bag is around 600 to 1000 ml depending upon the size. So this much of the size of reservoir we have increased from 50 ml when we were using nasal cannula to 100 to 200 ml when we were using face mask, and now to 600 to 1000 ml. So here you can give FiO2 of more than 50% and 60%. And if you are using non-rebreather mask, you can achieve up to 90% also FiO2 can be achieved with that. Now, the problem with using these equipment, these kind of devices is that because you are giving FiO2 at a higher rate, then there is a risk of absorption atelectasis, which I'll discuss in the complication also, and oxygen toxicity also. So if you see, this is the partial rebreather mask. Now, when you are using a rebreather mask with a reservoir, you have to be very sure that the oxygen flow should be between 8 to 15 liter per minute. As I said, when you are using plain mask, you should not keep the oxygen flow to less than 5 liter per minute. So here it should be more than 8 liter per minute, because we want to keep it at least half full even during inspiration. So continuous flushing has to be there, because when patient exhale with partial rebreather kind of a mask with reservoir, 1/3 of the initial air is going to enter into the bag. So if you're not keeping it flushed, then more of the exhaled air will enter into the bag, and it will, cause more of dilution of your oxygen, which is there in the reservoir. So this is, there are on the side also, you have these ports are there. So exhaled air maximum will be exhaled from there, but some air will enter into the bag because this bag does not have valve. And when patient inhales, the air from the bag comes and patient can inhale this. So whole of 300 to 700 ml tidal volume can be supplied of the 100% oxygen which is there. But just because of the mixing, you cannot reach higher FiO2. You can reach up to 0.80 FiO2 with non-rebreather, with rebreather kind of a face mask. Now coming to non-rebreather kind of a face mask, it basically has valve. If you see on the exhalation port also, there are 2 valves. So these are unidirectional valve. When patient exhales, the valves open, and this exhaled air goes out of these ports. And there is another valve which is there at the level of the reservoir. So this valve closes when patient is exhaling. So there is no entry of air into this reservoir bag. And when patient inhales, these 2 expiration valves will close, and only this inspiration valve on the reservoir will open up. And whatever patient inhales is 100% oxygen from the bag. So you can achieve FiO2 of more than 90% also if you are using non-rebreather kind of a mask. So this is, roughly a thing you should know that how much. So if your patient has hypoxia, but patient is stable, we try to start from a lower FiO2. But patients who are very sick, patients who come in shock, so there, initially we start with higher FiO2. We can give up to 0.40 or 0.60 FiO2, and gradually we can see when we are monitoring the patient if we can decrease the FiO2 of the patient. But patients who are more of stable hemodynamically, there we change. Then just a word about the fixed performance devices. These are the Venturi masks which are available. So basically, there is, this thing, I've just kept one mask in front of you. If you can see, there are these markings here, and you can adjust the opening of these ports here. So you can actually monitor the FiO2 which you will be giving. So it will not depend upon the patient's ventilatory problem. So where you want to be very precise, these kind of masks are excellent to be used, especially in patients of COPD. So bedside monitoring, we all know by ABG, pulse oximeter. Then complication is, one is absorption atelectasis, then oxygen toxicity to the bronchi and to the trachea. And then it can be extra pulmonary complication also, which can be suppression of erythropoiesis, decreased cardiac output or vasoconstriction. Then tissue injuries can be there. So this is roughly a chart about how to manage patients of acute hypoxia. If the patient's ventilation is not good, then you may have to straight away go on to the bag mask ventilation. If it is good, then in type 2 kind of respiratory failure, you aim for lower oxygen saturation. And if the patient does not have type 2 kind of respiratory failure, then aim for higher saturation. But if the patient is pregnant, aim for more than 95% saturation. Thank you so much.
Thank you so much, Dr. Rekha, for finishing such a large topic, done so well, extensively. You could take much longer over it, but you finished in time. Thank you for that and given a wonderful lecture. I think we'll do questions through the chat box. So can I request Dr. Gujral to introduce the next speaker?
Thank you, Gauri. Well, great pleasure to introduce Dr. Jyotsna Suri, and I think everyone knows her. She's Vice President AOG this particular year. They've done a wonderful job, wonderful conferences. The team was excellent. She's in charge of critical care obstetrics in the Safdarjung Hospital ever since it was founded in 2016. So you can see her interest and knowledge about the critical care. Many awards to her credit: WHO Fellowship, CS Dawn Prize, Abdul Kalam Prize, and an Academician Year Award, and so many books, so many papers. I wouldn't stand between you and the audience, Jyotsna. All yours. We're dying to hear you. Fluid therapy.
Very good afternoon to everyone. And I would like to thank Dr. Smita, Dr. Deepti, Dr. Nalini for giving this opportunity and for holding this workshop, which is actually the need of the hour. And also I'm very, thankful to our Safdarjung team, Dr. Pratima Mittal, who was the inspiration behind the critical care unit in our hospital, and which was set up in 2016. And our team, of which, Dr. Rekha has just finished, you all heard. So we are a very strong team, which is very dedicated, and the youngsters are all getting interested in this topic. And that is why such kind of workshops are really very important to, create more and more interest in them. Because at the moment, people think more about the IVF and endoscopy and all, which are no doubt very important. But this is, I think, something which has to be given more, more interest has to be developed amongst our juniors. So I start with this case. Mrs. X came to the emergency with a history of home delivery 2 hours ago, followed by retained placenta and massive bleeding per vagina. She reported to a district hospital. And when she reported, her pulse was 120 per minute. Her BP was 90/72. Her skin was cold and clammy. She was severely anemic. Her respiratory rate was 34 per minute, and her SpO2 on room air was 90%. On catheterization, only few drops of urine were drained, and all her clothes were soaked with blood. So the initial management by the casualty medical officer, a 20G cannula was secured, and saline with 20 units was started at the rate of 40 drops per minute. 2 units of blood was arranged, placenta removed, which was already separated and lying in the vagina. bleed controlled, and the patient was shifted to the ward with the order of transfusing 2 units of blood, which was transfused over the next 14 to 16 hours. So the second day, the patient started having decreased urine output. Her urea and creatinine, and third day, the urine output decreased further. Creatinine became 4.5. She started having hyperkalemia and metabolic acidemia. And day 4, the patient was sent to the higher center for hemodialysis. So this is the scenario with which we are receiving the patients. Almost every day we receive a patient like this. And at times I almost think that we have become a dialysis unit rather than an obstetric critical care, because we have 3 or 4 patients undergoing dialysis at a time. So the objective of this session is how to identify a patient in shock and determine if she requires fluid resuscitation. What are the types of IV fluids and which fluid is to be used when, and how to determine that the fluid resuscitation is adequate. So I start with what is shock. Shock is nothing but a state of impaired tissue oxygenation, which starts with the signs of circulatory failure and ends with cellular dysfunction or the cellular death, followed by the cellular death. And the oxygen delivery to the tissues is denoted by this formula, which is given below, in which we see that the cardiac output and the oxygen content in the blood are the most crucial determinants. So if we have to classify shock, we see that there are 4 types of shock: hypovolemic, distributive, obstructive, and cardio. And this is very important because when we are fluid therapy or fluid resuscitation, we need to classify that what kind of shock is it, and is she going to be fluid responsive or not. So the hypovolemic shock is a state of low preload because of the reduced intravascular volume, and there is an increased systemic vascular resistance in these cases, which leads to, in the beginning, a narrowing of the pulse pressure. So the main causes we see is the hemorrhage, and in some conditions, even the diarrhea, vomiting may lead to a hypovolemic shock in our patients. Distributive shock, we all are again very familiar as obstetricians, which is the condition of septic shock. Over here, there is a state of low systemic vascular resistance because of the pooling of blood. It is a vasodilatory state. And over here, the preload is also low, but not due to loss of the intravascular volume. Rather, it is due to pooling of blood in the peripheries. And the classic example, as we all know, is septic shock and also anaphylactic shock and neurogenic shock. The third one is the obstructive shock. Here, there is a low preload due to the obstruction of the venous return to the heart. And here, again, the increased SVR is there. The examples are the cardiac tamponade and pneumothorax, as well as a massive pulmonary embolism. Cardiogenic shock is there when there is a pump failure. So there is a low contractility of the heart, which leads to an increased preload as well as an increased SVR. So this is the condition in which we may see patients with acute MI, severe heart failure, and of course the cardiomyopathies. So with this background, we will be further talking about who needs fluid resuscitation. So before that, before we decide that we have to give fluid for our residents, how do they identify shock? So very, very important is the hypotension. So when we say in pregnancy, we all know that there is a decrease in the blood pressure, especially in the second trimester. So many times, the patient will have a systolic blood pressure of about 90 millimeter of mercury, which may be normal for her. So we strongly advise everybody now that when you have to, say that this patient is in shock, please calculate her mean arterial pressure. So mean arterial pressure is systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. Of course, it would help if you know the patient's, what was her baseline, and if it has fallen by 30 millimeter of mercury, the systolic, again, it is consistent with shock. But when the patient comes to us, many times we do not know what was her baseline blood pressure. Then, as I said, that narrowing of the pulse pressure, less than 25 millimeter of mercury is a very important early sign of hypovolemic shock, and we should not miss it. Tachycardia, we all know. Shock index. So a shock index is something which, again, I would like to highlight. Now it is compulsory in our hospital. All patients coming to emergency, the shock index has to be calculated and written. Simply heart rate divided by systolic blood pressure. So you can easily identify a patient who is deteriorating, a sick patient who may be in shock, especially if they come in, already they are hypertensive and they have come with, say, abruptio, concealed hemorrhage, and you don't know that they have bled inside. So the shock index in those cases is absolutely invaluable. So anything more than 1, we have to be very cautious, and it can definitely help us in, giving us an indication that our patient may be in shock. Respiratory rate more than 22 per minute. Cold extremities. Of course, in the septic shock in early stages, there are the warm peripheries. Altered mentation, oliguria, metabolic acidosis due to the high anion gap. Of course, here it will be the high anion gap due to the presence of the lactate. And, these all are the signs which help us to say that our patient is in shock. So out of all this, I stress on the shock index and the mean arterial pressure. And of course, altered mentation and oliguria are again very, very important. Now coming to what is fluid resuscitation. So fluid resuscitation is the administration of fluids rapidly and in boluses to patients with acutely impaired hemodynamic status. And then the next question is that who needs fluid resuscitation? So this is a very busy slide, and in the time I cannot be talking about this in detail. But what I want to say is when a patient comes in shock, you have diagnosed shock. In the beginning, you will give fluid challenge to any patient who comes, because at that moment you may not know the cause of shock. So if you give an initial, say, bolus of 250 to 500 cc, that is what you will do. But then you have to see whether she is fluid responsive or not, and take a quick history and make the diagnosis of the cause of shock. So here, the only 2 conditions in which you need to give the fluid resuscitation are the hypovolemic shock and the distributive shock. And in cardiogenic and obstructive shock, you may have initially given a fluid bolus, but later on then you will not give fluid resuscitation to this patient because she is not going to be fluid responsive. So we'll see what is fluid responsiveness also. So fluid resuscitation is required in all cases of hypovolemic and septic shock. Conventionally, it is used when the mean arterial pressure is less than 60, as we just discussed, and the CVP less than 8 millimeter of mercury in the absence of cardiogenic pulmonary edema. But however, lately, a lot of studies are showing that neither the MAP nor the CVP, which are both static measurements, are good indicators for those who need fluid resuscitation. And therefore, the importance about seeing the dynamic variables. So what is fluid responsiveness? It means that oxygen delivery to the tissue will improve after fluid administration, and giving a 500 milliliter bolus will improve the cardiac output by about 15%. So how to determine the fluid responsiveness clinically? It's a simple test, the passive leg raising test. So we see the blood pressure of the patient in this position with her head raised 45 degree. Then you make her lie down flat and raise her legs again by 45 degree for 2 to 3 minutes at least. And then again you measure her pulse pressure. So first you take the pulse pressure, that is the systolic minus diastolic. In this position, again you take the pulse pressure after about 3 minutes with the legs raised. And if there is an increase in 9%, that means that our patient is fluid responsive. So that means that she has actually, it is equivalent to a 300 ml bolus of blood going into the heart and increasing the cardiac output and increasing the blood pressure. So that is what the passive leg raising test is doing. The other test which we do is the Ivc collapsibility and the Ivc measurement. So this is, a very, very important test, point of care test, which we should be doing in our HDUs and ICUs. So in a spontaneously breathing patient, this is not for the patient on ventilator. We can, see that if the collapsibility with inspiration is more than 50%, the patient is fluid responsive. Now coming to which fluid to give, is it crystalloid or is it colloid? So we all know that the initial fluid resuscitation is with the crystalloid. If you see the property of the crystalloids, they have a low tendency to stay intravascular, only 30 minutes. And the solutes are of small size, small molecules. So they exert a lower oncotic pressure and they equilibrate between the interstitial space and intravascular compartment in a ratio of about 1:3 after half an hour. So giving too much of the crystalloids can lead to the overload, the pulmonary and the cerebral edema. And in spite of all this, we use it for the immediate resuscitation of lost volume. Colloids have a high tendency to stay intravascular because they have got larger molecules which exert greater oncotic pressure. The volume expansion is for a greater number of hours. And we know that there are the natural colloids like the FFP and albumin as well as the synthetic ones. But we are not using it for initial resuscitation. However, we use it in some situations of massive blood loss till we get the blood products after the initial fluid resuscitation with crystalloids has been done. So why we do not use colloids for initial resuscitation is because of the very high risk of anaphylaxis, coagulation abnormalities, and acute kidney injury, especially with the hydroxyethyl starch solutions. If you give large volumes, that is one of the very important risks with them. And eventually these solutes also enter the interstitial space and hold a lot of water in that space and may lead to pulmonary edema later on. So if you see, the composition of some of the common crystalloids we use, we see that the lactated ringer is the most physiological amongst what is available to us. And it is these lactated ringer and the 0.9 NaCl, that is the normal saline, which is being used for the fluid resuscitation. There is a buffered saline also, which is now available, but it is expensive and we do not have it freely. So we are not using it for initial fluid resuscitation in most of the institutes in our country. Dextrose is D5W. So it is only isotonic as long as it is outside the body. The minute you transfuse it, it becomes hypotonic because the dextrose is metabolized and what is left is water. So immediately this water will equilibrate into the cells and between the cell interstitium and the intravascular compartment and lead to the cellular edema. So this D5W should never be given in large volumes for fluid resuscitation. And we are very, very cautious about D5W in preeclampsia, where already there is a propensity for cerebral edema. Now, out of the two, saline and ringer lactate, both of them are actually kind of equivalent, even though RL is more physiological. So if both are available, we do tend to use RL. One thing about RL, if there is hyperkalemia, because it has got potassium, RL has got potassium, very low amount, not a very, very big concern, but we try to avoid it. And it should not be given along with in the same line with the blood transfusion, because again, it has got calcium in it, and this can chelate with the citrate in the blood. So normal saline, if we give large volumes, the problem is a normal anion gap, metabolic acidemia may take place. So if you are giving more than 2 liters, we should be careful about that. And some studies are saying that even, giving massive transfusion with saline may lead to renal dysfunction. So which fluid to give? In hypoglycemia, it is D5W, and D50, you can use D25. Hypotension, always ringer lactate and saline. And hyponatremia, we can use the 3% saline also. That is the hypertonic saline. How do we administer? We always give through the 18G or the 16G or the 14G, but never 20G, because you have to give it fast. You have to give it in boluses to improve the cardiac output. Otherwise, you will end up just, giving the fluid slowly will just equilibrate it between the interstitial and the intravascular compartment, and your increase of cardiac output will not take place. So this is a very important message for our residents. Always put the green, at least this is the minimum acceptable for fluid resuscitation. If you don't have a peripheral line and you cannot put a CVP, there is the intraosseous access also, which is being taught in the emergencies these days. So this part I will not be talking, but how much fluid to be given will be assessed by the amount of blood lost, which I think will be covered in another session on PPH. So how to administer fluids? Always in boluses. Give it as a bolus of 500 ml to 1 liter at a time. In septic shock, 30 ml per kg body weight as the initial fluid challenge over the first 3 hours is recommended by Surviving Sepsis Campaign guidelines. In PPH, it is recommended 1 liter over the first 15 minutes, reassess the patient, and 2nd liter over the next 40 minutes. So 2 liter basically over the first hour should be given in PPH. In women with mild CCF and end-stage renal disease, you give smaller boluses, not 1 liter, but you can give at boluses of 250 to 500 ml. And another important thing, keep the patient warm. Fluids to be run through fluid warmer if the ambient temperature is cold. And otherwise, you may end up with hypothermia in the patient, and sympathetic stimulation will take place, myocardial ischemia, sepsis, and coagulopathy. So this can actually worsen our patient. So be careful about this issue. Correct metabolic acidemia with bicarbonate if pH is less than 7.15. And keep assessing your patient after all the boluses you are giving. So look for crepitations. Is she going, or you can do the passive leg raising test after each bolus. You can see the IVC if you've got your echo probe with you. You can do that also. And keep seeing her mean arterial pressure. Urine output is a very sensitive indicator. Normalize mental status, normalize lactate. And important is that heart rate is not a reliable indicator of adequate resuscitation. So don't rely on the heart rate. So to end, I would like to give the key messages. Dynamic tests like echo are preferred over static tests like CVP to determine fluid responsiveness. IV fluid should be administered in discrete boluses through a wide bore short cannula. Initial fluid replacement should be with an isotonic crystalloid solution. Lactated ringer or normal saline are fluids of choice for resuscitation in shock and are almost comparable. D5W should never be used as a resuscitative fluid. Large volume resuscitation using isotonic saline may be associated with the development of hyperchloremic metabolic acidemia. Lactated ringer should not be infused in the same line as blood. Replace 1 liter in first 15 minutes and 2nd liter over 45 minutes in hemorrhagic shock pending availability of blood. And for patients with severe hemorrhagic hypovolemic shock, red blood cell transfusion is actually the most appropriate choice for initial fluid volume resuscitation. For septic shock, it is the crystalloid at the rate of 30 ml per kg body weight of, in discrete boluses can be given, and start vasopressors in the first hour itself. Monitor the signs for adequate fluid resuscitation continuously after each bolus. So thank you very much. This is a picture of our critical care unit, and that's all I would like to speak in this topic today.
The first part, oxygen, we know nothing. That's the only thing I can say. So many types of masks, this, that. Honestly, we only know the nasal plong or little plastic thing which comes on it. So I think it's time we learned our rebreathers and all those masks, I think there should be some demos to all of us also. Right. The second part, fine, fluid balance. She's made it very clear, good revision, good new add-ons. And I really compliment both the speakers. They've done a very, very good job.
Excellent.
Oxygen, nothing.
Actually, fluid management, I think an obstetrician learns from the day they enter obstetrics. Yeah. We always have bleeding and pouring patients, and some amount to along our practice learn. Jyotsna, I've never seen the red colored 14 number catheter in all these years. We started with the gray colored 16. Aapke yahan 14 bhi aata hai?
Haan, aata hai, but actually, madam, it's more a theoretical, because we are not, when they are in shock, it's very difficult even to put in a 18 G catheter.
बिल्कुल।
So,
तो अगर
we can do
16
it the grade. 14
18 भी चला जाए तो it's great.
it's a very big thing. So only thing is that we encourage them that they should only put the green. If it is possible, they can put 16, but 14 is very difficult actually.
I've actually never seen that in
No,
my.
it's available. Yes, ma'am, it's available. And now we are procuring the, we are procuring even the intraosseous needle also for
Right.
emergency, because that is something, you know, if the anesthesiologists are not around to put the CVP line immediately, and sometimes the patient may be having some deranged platelet count or INR or something, they don't want to put a CVP. So it's our emergency has got it, and gynae emergency is also in the process of procuring it.
Yes, and the other thing that I think our PGs have to look out for, I find often there's hyperperfusion, as you mentioned, leading to cardiac failure rather than bringing the patient out. So this balance of how much liquid to how much fluids to perfuse is very important.
Yes, yes.
So I don't see any questions in the chat. The mask lines are masks with reservoir. They are not used in hospitals. Somebody has made that comment.
No, ma'am. Actually, somebody had asked which kind of masks are used in the airlines. Actually, they are actually designed for airlines. We are not using those masks in the hospital.
Right. I just saw that remark.
No,
I don't see any other questions.
Good afternoon, ma'am. Ma'am, there are a few questions. The first question is for Rekha, ma'am. That what flow can be given through the Venturi mask and how is it different from the simple oxygen mask?
Yeah, from Venturi mask, I actually kept this Venturi mask because I knew when many of the people have not seen it. So if you see it clearly, there are certain markings on this mask. So it is also written the rate of oxygen which you have to keep, 3 liters or 6 liters per minute. And if you want to give FiO2 of 24%, there is an arrow here. Just take this arrow to this line where it joins with 24%. So this is with the 3 liters oxygen. If you put it here, this will deliver at 24%. And this all is controlled from this, this outlet which is here. So this keeps closing as you want to increase the FiO2. So this is if you have to make it 26%, see how much it has closed now. And for higher percentages from 35 to 50%, you have to increase the flow rate of the oxygen to 6 liters per minute. So you just have to adjust, this basically arrow you have to adjust corresponding to the percentage which is written here, and the flow rate also is written here. So just have to follow the instructions. So that is why, you don't have to calculate anything, and a calculated FiO2 will go to the patient. So this is why, but the only problem is it is costly. As initially I said, when you choose a mask device, you have to see the cost also. So it may sound very convenient that everything is written, you take this and up to 50% you can do with this Venturi mask, but then cost is also one thing which you should keep in mind when you are choosing the devices.
Thank you, ma'am, for the detailed description.
There is another question, Nalini. Now I see the questions. This is about fluid replacement. What fluid should be preferred in case of metabolic acidosis versus metabolic alkalosis? Normal saline or ringer lactate?
Metabolic acidosis, definitely, any patient in shock will have metabolic acidosis. And we can give, I very clearly said that we can give either of the fluid. Saline is much cheaper than ringer lactate. So many of the, especially in the primary health centers or maybe CHCs, if the ringer lactate is not available, there is no issue. We can start our fluid resuscitation with saline, and there is no problem. But only giving more than 2 liters can lead to non-anion gap metabolic acidemia if we are giving very high volume. So up to 2 liters, you can give saline. There is not a problem. Ringer lactate only if there is already hyperkalemia. So we have to be little cautious about that, and don't give it in the same line as the blood. Otherwise, there is no problem. We are actually, we normally give ringer lactate in our own institute. We give it as the first choice.
Now, Jyotsna, they want to know the difference when the patient is manifesting acidosis versus metabolic alkalosis. Is there any difference?
Ma'am, there will be acidosis in shock. So most of the time there will be acidosis, and alkalosis, we don't expect, except there may be alkalosis if the patient is hyperventilating or she is having a pulmonary edema. Sometimes she may have alkalosis, but we can give either fluid in both the situations. There is no problem.
No, sorry to interrupt, but we have
only
to
if she is already acid. Yeah.
We have to
Only
wind
if she
that.
is already acidic, we will not give fluid. That is all.
Right, right.
Already if she is having 1 anion gap acidosis.
So I think we've been reminded by the organizers that we have to wind up this session. I thank the speakers, the wonderful talks, really, and we need to spend more time on these topics. It was great. Thank you all very much. And thank you to the organizers, Deepti, Smita, for inviting us.
And thank you, organizers. Thank you. Yeah, thank you.
Hand over to you, Nalini.
Anji. Thank you, ma'am. Thank you. And congratulations, Jyotsna ma'am and Rekha ma'am, for this excellent, wonderful talk and great insight into the key concepts of critical care. And thank you, our chairpersons, to be the part of this conference. Now we are moving to the session 2, which is preventing the direct maternal mortality. And the chairperson for the session 2 is Dr. Y.M. Mala ma'am. She is a director professor of the Department of Maulana Azad Medical College. And ma'am has various affiliations and her key interest in oncology, endoscopy, and HIV medicine. Then Dr. Pratima Mittal ma'am, she is the pioneer in establishing the obstetrical critical care unit in Vardhaman Medical College and Safdarjung Hospital. She is an honorary fellow of RCOG, vice president of FOXI in 2018 and president of AOGD 2015 to 16. And she is a member technical resource group of Ministry of Health and Welfare, Government of India for adolescent health, mental health, contraceptive and comprehensive abortion care and maternal death review. Ma'am has many publications and she is one of the pioneers of critical care in obstetricians. Welcome, ma'am. And Dr. Daru Gupta ma'am, she is professor with more than 24 years of experience and a key interest in managing the high-risk pregnancy, advanced endoscopic surgery and gynae-oncology. Ma'am is also a trainer of emergency ops care, and she's a life member of AOGD, NARCHI, DGHS, and FOXI, and ma'am has numerous publications at her credit. Welcome, ma'am.
Good evening. First of all, I would like to congratulate Dr. Asmita and Dr. Ranjana for, organizing a webinar on such an important topic. And secondly, I would really appreciate the efforts of Dr. Deepti and Dr. Garima, Dr. Nalini, who has really meticulously planned the sessions and they worked to the smallest detail of for the webinar, and each and everything has been taken care of. Thank you, Nalini, and thank you, Deepti, and thank you, Asmita and Dr. Ranjana for inviting me. And coming to the topic, maternal mortality in today's era, we have really, as a country, we are really doing well. Our maternal mortality has fallen to 113. 113 per 100,000. And that is because of basically, when we have given importance to the complications of the pregnancy related issues, especially the hemorrhage, predicting hypertensive disorders, all these things have really contributed in reducing the maternal mortality in our country. And on talking of the topic of life-threatening hypertensive complications, we have none other than Dr. Sangeeta Gupta, who is Director Professor in Obstetrics and Gynecology at Maulana Azad Medical College. She has established fetal medicine clinic at MAMC and Lok Nayak Hospital, and has vast experience in the invasive procedure. She has been awarded Commonwealth Scholarship in the year 2007. She is faculty for BA FNB training program, member of WHO CRO project for stillbirth, working with the Safdarjung Hospital, working as a nodal center for this, multiple publications and contribution to various textbooks. And on top of it, I think she's a great person and she's a really good friend. So welcome, Dr. Sangeeta. I invite you to give your talk.
Yeah.
Yes, ma'am.
So good evening, everybody. Today I have been asked to speak on the life-threatening hypertensive complications. And we all are aware that in the developed world, the incidence of severe preeclampsia, eclampsia, and maternal deaths has been drastically brought down. However, in the developing world, we are still confronting this challenge. In India, about 24% of maternal mortality can be attributed to preeclampsia, in contrast to the Western world where the incidence has fallen to 10%. And the women with preeclampsia and eclampsia have almost 3 to 25-fold increase in severe complications like abruption, thrombocytopenia, DIC, pulmonary edema, and aspiration. And all these are making significant contribution to mortality in women. And even the severe obstetric complications was 3 to 35 times hospitalization rate is there in these women. To combat it, we need to have a multidisciplinary approach where we have a maternal medicine, an emergency medicine, an anesthetist, and a critical care person available. And these patients are ideally managed in ICU or critical care settings. Next, please. So, next, please. Yeah. So this is a slide which enumerates the common life-threatening complications of preeclampsia. However, I'm going to skip eclampsia in my discussion today because all of us are well versed with its diagnosis and management. And I would like to quickly cover the rest of this, which is acute renal failure, pulmonary edema, intracranial hemorrhage. I'll be briefly touching HELP and then talking about liver hemorrhage. Next slide, please. So coming to acute kidney injury and preeclampsia, hypertensive disorders of pregnancy are an important contributor to the burden of acute renal injury in pregnancy, particularly when the patient has HELP or abruption. And it has been seen that acute kidney injury is seen in about 7 to 60% of HELP, which has been reported by various researchers. If there is coexistence of HELP and acute kidney injury, there is a very high prevalence of placental abruption, postpartum hemorrhage, and pulmonary edema. As I go by, you will realize that these life-threatening complications hardly ever exist as isolation in preeclampsia, and there is a huge coexistence and overlap. And acute kidney injury is an important risk factor for maternal mortality, especially in cases of HELP class 1, where the platelet count is less than 50,000 per cc. 20% of women who develop AKI during preeclampsia require dialysis, and the maternal mortality rate in these women is to the order of about 15%. And it has also been seen that they are at a higher risk of developing chronic renal disease and end-stage renal disease, especially when it is associated with a acute cortical necrosis. Usually this complications develops in the postpartum period, and the diagnosis can be picked up by oliguria and abrupt rise in serum creatinine. The core management is always the same as for any patient of preeclampsia, where immediate delivery of the placenta and fetus with antihypertensives and magnesium sulfate therapy should be initiated. However, in patients of acute kidney injury, either one has to withhold it or it has to be titrated with serum magnesium levels. Now, invasive hemodynamic monitoring is debated in these patients. Like Dr. Jyotsna has just said, that now it is the dynamic tests which are more useful in doing fluid replacement. An accurate fluid assessment is very essential, hence a Foley's catheter is inserted and a strict input-output chart with hourly monitoring is done. Once we talk of fluid management, we should refrain from aggressive fluid management as this precipitates pulmonary edema. So the patients should be given small incremental boluses, and we should keep a strict eye on the output, and the aim is to maintain an output just above 30 ml per hour. And the total output over 24 hours can be calculated by the previous day output plus 500 ml for the insensible losses. Now, this total volume should go distributed over 24 hours and should not be given in a few hours. Diuretics are indicated sometimes during the oliguric phase of acute tubular necrosis. These patients may require dialysis if there is a hyperkalemia or acidosis which is resistant to medical therapy. There's a fluid overload which you cannot again tackle with medical therapy, or there is a uremic encephalopathy. And as I've already told, that about 20% of patients of HELP will require dialysis. Next slide, please. Now, a word of caution here. As I've already said, that there is no these disorders usually are not isolated in preeclampsia. Either they're associated with blood loss. Here, the hypotension masks the coexistent hypertension, and it can be diagnosed sometimes by a low CVP if one has a CVP line in place. However, you should avoid diuresis here till the volume depletion has been corrected. Then it can coexist with coagulopathy. So one needs to do adequate replacement with either FFPs or platelets as required. And again, when you're doing it, you have to keep a watch on the output. Now, immediate postpartum period with mild renal impairment and oliguria is not of uncommon occurrence, and one should manage this. If this is mild, one can just manage it conservatively with observation. It is better to err on side of volume depletion, and there should be no aggressive fluid replacement done, in contrast of oliguria because of other reasons, which we usually see in our ICUs, like patients who have lost blood. And in these cases, again, diuretics should be withheld unless associated fluid overload is suspected. And very important to remember in patients of preeclampsia, especially those with acute renal failure, is to avoid non-steroidal anti-inflammatory drugs. We already know that they are renotoxic. They delay the resolution of renal injury, and along with it, they cause persistent postpartum hypertension. Next, please. So next, I would like to discuss pulmonary edema in preeclampsia. 3% of women with preeclampsia develop pulmonary edema, and the maternal mortality in these women is to the order of about 10%. The pulmonary edema of preeclampsia is of both cardiogenic and non-cardiogenic etiology. The cardiogenic component comes because of the left heart failure, whereas the non-cardiogenic component is attributed to the leaky capillaries in the alveoli, and because of this, the management becomes more challenging. Now, 70% of women develop pulmonary edema in the postpartum period, followed, and another huge set of women will precipitate postpartum this pulmonary edema in the during labor. What is very important to remember is that pre-existing chronic hypertension is a major risk factor for development of pulmonary edema. So almost 90% of women who develop pulmonary edema will have a pre-existing chronic hypertension. As far as the features of pulmonary edema are concerned, there can be a history of fluid overload, which is very commonly seen in our settings, that we are not able to assess the amount of fluid to be given. And there is, if you go into the history and you evaluate the input-output chart, one often picks up that there is a fluid overload. The another thing which I want to assert here is that tachypnea during pregnancy should never be taken non-seriously. And this is where we pick up these patients' tachypnea with shortness of breath. And the important investigations here are chest X-ray and ABG, along with the complete preeclampsia profile. As I said, these disorders usually coexist with other complications. So the differential diagnosis of pulmonary edema can be a postpartum cardiomyopathy or an ischemic or a valvular heart disease, where an ECG and echo will become handy in making the correct diagnosis. It could be an infective pneumonitis or an aspiration pneumonitis, or it could be drug induced. Next slide, please. So management principles here are to establish early diagnosis and know the cause of pulmonary edema, improve oxygenation, and treat the cause. Intensive monitoring is again going to be a very key factor in these women. So they should be ideally transferred to ICUs. Once you pick up pulmonary edema, they should be transferred to ICU where an invasive monitoring can be done. A judicious and restricted fluid therapy is very important. Again, titrated volumes have to be administered. One needs to maintain oxygen saturation aggressively, and sometimes even ventilatory support may be required, which may be either non-invasive or invasive. Next slide, please. Aggressive management of hypertension is very important because it helps us in decreasing the afterload, and diuretics are again a very important part of management as it decreases the preload. Usually we withhold diuretics in preeclampsia, but when it comes to pulmonary edema, we must manage these patients with diuretics. There is a role of NTG drip also. It is particularly useful in pulmonary edema where diuretics are ineffective. The dose is 5 micrograms per minute. You can increase every 5 minutes and can go up to a maximum of 100 micrograms per minute. Morphine is another very good adjuvant. Can be used if there are no signs of imminent respiratory failure, which can be picked up by a rise in PaCO2 on the ABG. Now, as far as magnesium sulfate is concerned, there are debated views on it. It adds to pulmonary edema, so it is contraindicated as per the RCOG guidelines. However, some advocate careful administration in small volumes with strict fluid restriction. And last but not the least, delivery is the answer after stabilizing the patient. Next, coming to another very important complication, which is life-threatening, is intracranial hemorrhage, which accounts for about 10% of maternal deaths in pregnant women. Now, pre-eclampsia contributes to 14 to 50% of pregnancy-associated intracerebral hemorrhage. And 44% cases are secondary to eclampsia. So one can realize how many so many eclamptic patients whom we lose are probably because of intracranial hemorrhage. Again, this complication is clustered around labor and postpartum period. So you can imagine how important it is to observe the woman in the postpartum period. I'm not going to go into the details of mechanism of action. However, there's an important, next slide, please. Important point which I would like to assert here is that intracranial hemorrhage has been associated with severe systolic BP rather than the diastolic BP. And they have observed that if you measure the pulse pressure, and if it is pulse pressure is the difference between the systolic and the diastolic pressure, and if it is more than 60 millimeters of mercury, and there is a systolic blood pressure of more than 60 millimeters of mercury over the baseline, this can become a very important marker for picking up impending intracranial hemorrhage in women with severe preeclampsia and eclampsia. People have said that the substandard treatment of high systolic blood pressure is probably contributing to intracerebral hemorrhage, and hence people are advocating aggressive treatment of severe hypertension, particularly the systolic blood pressures. Next slide, please. Next slide, please. So the clinical features are, they have a huge overlap with features of eclampsia. However, there can be focal neurological deficits, hemiparesis, which help you to pick up this diagnosis, clinch this diagnosis, and the presence of non-reactive pupils strongly favors intracranial hemorrhage. The differential diagnosis can be an ischemic stroke, an impending eclampsia, a dural puncture, or a migraine, and the diagnosis can be safely made with a plain CT, which is very easily available and quite safe in pregnancy and sensitive to detect acute blood loss. Next slide, please. Management, delivery, instant delivery, usually by cesarean section, is very important. Magnesium sulfate and antihypertensive therapy have to be started. Labetalol is the drug of choice because it has got a very good effect on decreasing the cerebral perfusion pressure without compromising the cerebral oxygenation. If coexistent coagulopathy or platelet deficiencies, their replacement has to be done. And if there is any anticoagulant therapy going on, one must stop it and administer the antidote. IV mannitol has a role in decreasing the cerebral edema. As far as neurosurgical interventions are concerned, the role of a neurosurgeon cannot be overemphasized here. And a concomitant cesarean section and craniotomy is the ideal situation. However, most of the times, there is a delay in surgical intervention for the intracranial hemorrhage because either there is a delay in diagnosis or there is non-availability of the neurosurgical expertise. The various options available are decompression, craniotomy, or even embolization has been tried, which is usually indicated when there is a large intracranial hemorrhage with mass effect, or there is a declining consciousness or worsening of neurological deficits. However, conservative management is also advocated when there is a small non-progressive hematoma or there's thrombocytopenia, uncontrolled hypertension, or sometimes when there is a very massive bleed with a very poor outcome. I just have to say a few words about HELP, that 12 to 14% of preeclamptic women have HELP, and the maternal mortality can be as high as 25%. And the contributors are abruption, pulmonary edema, ARDS, acute kidney injury, DIC, and ruptured liver hematomas. So I think the identification and expert management of HELP is very, very important. I will not go beyond this. And again, HELP is commonly seen in intrapartum and postpartum period. Last of all, I will be talking about liver hematomas. The incidence is very low. They are very rare. Again, very highly associated with HELP. Clinical features are pain, right upper quadrant, and shoulder pain, and hypovolemia is associated. They can be picked up usually on ultrasounds. Next slide, please. The management again here is delivery, and if you suspect liver hematomas during a cesarean section, one must explore the liver and manage, do a surgical intervention if required. Replacement of blood and blood products is mandatory. There is a word about the word on the conservative management, where the patients are hemodynamically stable with intensive medical support, and one may try a percutaneous hepatic artery embolization. The options of hemorrhagic management can be either singularly or in combination of packing, drainage, hepatic artery ligation, or hepatic resection. And very, very rarely, when there is acute liver failure associated, transplant has been mentioned in the literature. Next slide, please. So with this, I come to the end of managing some not very infrequent life-threatening complications, but not very frequently picked up, and we have lesser experience in managing these women. So the take-home messages here are that postpartum period in severe preeclampsia needs intensive and vigilant monitoring, I think, which I have brought up very clearly in this talk. Acute kidney injury, pulmonary edema, and intracranial hemorrhages are commonly and very usually seen in the postpartum period, and a significant number of HELP also develops in the postpartum period. There is a coexistence of these life-threatening complications which pose a diagnostic and management challenge, and hence multidisciplinary approach in an ICU setting gives optimal outcome. And we should keep a high index of suspicion. Like, there is a fluid overload, where once there is an acute kidney injury, there is a fluid overload, and then there is a pulmonary edema, or there is an abruption coexisting with DIC and acute kidney injury. So this kind of a multifaceted life-threatening complications makes it really very, very difficult and challenging to manage these patients. And at the end, prevention, primary prevention with aspirin administration in first trimester, and treatment of hypertension in preeclampsia should be advocated. The target systolic BP should be 110 to 140 millimeters of mercury, and diastolic 85 millimeters of mercury, as recommended by ISHEP 2018. So in the end, I would just like to re-emphasize that we should not wait for BPs to shoot to 160 and 110 probably, and we need to bring down the thresholds for managing severe hypertension with oral drug therapies as well. Thank you so much.
Now I request Adu ma'am to invite our next speaker.
Okay. At the outset, I would like to thank Dr. Asmita Rathod ma'am and the organizing team for making me part of this webinar on a very important topic. And in fact, it is indeed a great honor for me to chair the session with Dr. Pratima Mittal madam. Now, after discussing the complications of hypertension in pregnancy, now let's move on to the next, that is the third most common cause of the maternal mortality, maternal sepsis. We know that maternal sepsis is a life-threatening organ dysfunction resulting from infection during pregnancy, during childbirth, post-abortion, or a postpartum period. For this, we have with us Dr. Jyotsna. She is a senior consultant at Kasturba Hospital. She has done WHO fellowship in high-risk pregnancy from PGI Chandigarh, also done fellowship in minimal invasive surgery and diploma from Germany. She is a faculty and a course coordinator and an examiner for RCOG. So a very keen academician. Welcome, Dr. Jyotsna. Kindly give your presentation on the maternal sepsis.
Thank you, ma'am. And at the outset, I would like to thank the organizers for giving me this opportunity to speak on this topic. I'm just sharing my slide. So sepsis and septic shock. As we know that sepsis is the third direct cause of maternal death after hemorrhage and hypertension and accounts for almost 11% of maternal deaths. Now, why are we worried about sepsis? Because of the mortality. In sepsis, there is 30 to 50% mortality, and in septic shock, 50 to 60%. That means 1 in 2 landing up in the ICU with septic shock will die. Now, what is important is this is a preventable cause. And in the confidential inquiry to maternal death, it was found that 63% was substandard care, most often a delay in recognition or management. And this is the important thing. You can see the clock. The first hour is very, very important in bringing out the best outcome in sepsis. The third international consensus definition of sepsis and septic shock was given in 2016. This shows that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So to make it simpler, this is what it is. With infection, if you have a regulated host response, most of them are cured. But if there's a dysregulated host response, you'll have life-threatening organ dysfunction, and this is what is sepsis. On the other hand, if you have a life-threatening organ dysfunction with infection and hyperperfusion, that is hypotension, not responding to fluids and requiring vasopressors to maintain a MAP of 65 millimeter of mercury and with an elevated lactate, then this is a case of septic shock. What's a pathogenesis? Now, we all know from the COVID era, the bacterial toxins cause massive cytokine release, and it causes a lot of intermediate reaction, but ultimately there's hemodynamic collapse leading to respiratory failure, shock, renal failure, and DIC. The most common causes of sepsis in pregnancy, as you can see in obstetric, it is septic abortion in chorioamnitis and endometritis and wound infection in postpartum. Now, to understand sepsis better, we should be knowing about Surviving Sepsis Campaign. This is a Society of Critical Care Medicine and European Society of Intensive Care Medicine. They are collaborator, and they had got together to bring out guidelines which would improve the outcome of sepsis. Now, this is the history. They started in 2002, and they started meeting every 4 years and provided to us guidelines after analyzing the meta-analysis and the random randomized trials. And the latest one is 2021 adult guideline, and to which I shall be talking in my talk. These people are the ones who also brought out the sepsis bundle management, septic management bundles. These are a series of actions which are supposed to be completed within that particular hour. So in 2004, they brought out the 6-hour and the 24-hour bundle. And in 2013, that was converted to a 3-hour and 6-hour bundle. And now in 2018, this is 1-hour bundle. Now, adhering to this bundle is the key important factor for getting a good outcome in septic shock. Now, this is the 1-hour bundle. It says that you have to measure the lactate level first, obtain blood cultures, administer broad spectrum antibiotics, deliver 30 ml per kg crystalloid, apply vasoactive medications to maintain MAM, to have a target MAP of 65 millimeter mercury. All elements may not finish within the hour, but what is important is it should be started and completed within 3 hours. Now, along with this, the UK people have added another thing is that administration of high flow oxygen and monitoring urine output, and to it they call as sepsis 6. Now we start with a case history. This is a 28-year-old primary gravida with type 2 diabetes. She had cesarean for breech. She had history of treatment for 3 episodes of UTI in the ANC period, and the last one was just 2 weeks ago. She was discharged on day 3. On day 4, she developed rigors, and she contacted her local doctor or the midwife, and the midwife was asked her to take the temperature. Her temperature was found to be normal, and the midwife dismissed it as pain related. On day 5, she had nausea and 2 episodes of vomiting and rigors, and she was seen by a GP in the afternoon, where her heart rate was 110 per minute, BP 80/60, respiratory rate 27, temperature 101, and she was referred to the hospital. She reached the hospital a little late, and she was found to be hypoxic on room air with elevated lactate. Now, what is the diagnosis and what is the management? We'll learn gradually as we go through this. The risk factor for maternal sepsis is obstetric. Operative intervention, cesarean section, and prolonged rupture of membranes are the greatest risk factor in obstetric. And in patient-related, primipara and pre-existing medical condition, obesity, antibiotic use prior to 2 weeks of presentation. Management of sepsis and septic shock. It is early identification, initial resuscitation, infection control, hemodynamic management, ventilation, and supportive measures. We shall talk all about this as we go by. Early identification of sepsis. We use certain screening tools. This is the SOFA score, which is known as the Sequential Organ Failure Assessment Score. The Q-SOFA, which is Quick SOFA, the Obstetric Modified Q-SOFA, the Modified Early Obstetric Warning System, that is the MEOS. Now, all of them, they include vital signs and clinical evaluation, and some of them do include laboratory parameters. The important thing is that there's a wide variation in diagnostic accuracy, and most have poor predictive values. In other words, these screening tools help us to screen for sepsis, but they're not great in picking up on their own itself. We have to combine a few scores together. Now, this is the Q-SOFA, which just has 3 clinical parameters, and it is used outside the ICU. That means you can use the ward to diagnose patients who are at risk of organ function or who are having organ function and need an elevated level of care. Now, any score more than 2 points, sepsis is likely to be present. Now, this Q-SOFA cannot be used in pregnancy because many of the physiological adaptation of pregnancy overlaps on this. So there was a modification brought about by the Obstetric Medicine Unit of Australia and New Zealand. This is Soman Society, and this is known as a modified Q-SOFA, where they put the systolic BP as less than 90, respiratory rate more than 25, and altered mental status. Again, a score more than 2 indicates that the patient is having organ dysfunction and needs an elevated level of care and an early transfer to the ICU. Now, this is the MEOS chart. This has got a better sensitivity rate and is used in UK. And you can see this, if the patient scores 2 yellow triggers or 1 trigger, then a senior anesthetist and obstetrician must be called. That means there is a senior input there, a sepsis screen is done, and this patient's care is elevated. So you can diagnose sepsis early using these scores. Now, the SOFA score, this is an ICU score, which is used mostly in the ICU. And the important aspect of this score is any score more than 2, acute change in the score of more than 2 indicates that the patient is having sepsis. But the difference from the other scores is that this uses a pharmacological parameter, that means dopamine rate, and for scoring. And the other thing is that in pregnancy, this score has to be modified. And as you can see, a 0 score is normal, but a 1 score to 4 is the one which is given at different elevations. Now, creatinine 1.2 is given a score of 1, which is supposed to be very high in pregnancy. So this cannot be used in pregnancy. The creatinine level has been corrected to 1.02 to be given as a score of 1. And similarly, as a MAP less than 70 is given as a score of 1, but in pregnancy, normal pregnancy, a MAP less than 70 is usual. Early treatment, initial resuscitation, mean arterial pressure aim is to maintain it at 65 millimeter mercury, ICU admission within 6 hours, and most important is adherence to the 1-hour bundle. Initial resuscitation, as we have all heard, 30 ml per kg IV crystalloid within the first hour should be given within the first 3 hours. Now, in pregnancy, this might cause a little more overload. It is better to give between 1 to 2 liters. As we have all seen, dynamic measures should guide resuscitation over physical examination, and resuscitation should be guided to decrease the serum lactate level. Capillary refill time can also be used to guide resuscitation, and the normal capillary refill time is less than 2. If it is more than 2 seconds, that means there is hypoperfusion and the patient needs fluid. Heart rate, central venous pressure, systolic blood pressure, they are poor indicators of fluid responsiveness. Now, in septic shock, as you said, some patients will be fluid responsive, some patients will not be fluid responsive. To know them, you have to have the dynamic measures in place. Dynamic measures has already been taught. I won't touch on this. This is the passive leg raising test, and where there's increase in 15% increase in the pulse pressure. Now, lactate clearance for prognosis. Now, you can see in this graph that why the lactate clearance is important. In septic shock, there is hypoxia, and the tissues go back to anaerobic metabolism, producing lactate. So if the lactate is not cleared, it indicates mortality. So in this particular graph, it is seen that those who clear the lactans, in that group, the mortality rate is 19%. But those who were not able to clear the lactate, even after 40 days, the mortality rate was very high, that is 60. So the aim of perfusion should be to decrease the lactate. This is what the target lactate should be normal and MAP at 65 millimeter mercury. Now, infection control is the next very important step, and we should be knowing how to diagnose, what should be the timing of antibiotics, the biomarkers, source control, and de-escalation, and we shall go through that. Now, diagnosis of infection, there's no gold standard. We do all these blood investigation cultures from all possible sites, image for source, ultrasound, and CT. A word about blood cultures. In adult, it should be 10 ml per bottle, and it should be of the adequate amount. If it is low volume, that will give wrong results. And if it is overfilled also, that gives wrong result. Another thing is that the cultures should ideally be of 2 sets. One set should be from the aerobic and the anaerobic culture. And one should take one from the percutaneous route and other from any vessel access site, because these access sites are the ones which carry infection. And if the cultures are negative, then you can also use certain molecular techniques like the peptide nucleic acid in situ hybridization or the PCR-based systems. Antibiotics, the early administration of appropriate antibiotics is the single factor that determines survival in sepsis. The principle is administer within the first 1 hour. There is a 7% mortality with every 1 hour delay. Now, this is a landmark paper. It's a very old paper, but it does suggest that the duration of hypotension before initiation of antimicrobial is a critical determinant of survival in human septic shock. As you can see, if the antibiotics is given within 1 hour, then there is 80% survival, and survival decreases 7.6% with each hour of delay. Now, this is another landmark paper which shows that if you have initiated antibiotic within half an hour, then the survival is 80%. But if you give it after 5 hours, the survival falls to another 40%. And in this particular paper, it was also seen that within the first 6 hours, patients who were admitted to ICU, only 50% of the patient in septic shock received antibiotics. So it's very important that you give the antibiotic in the first 1 hour. Now, why should we give empirical antibiotics? Because waiting for cultures may be too late. Only 30% of patients with presumed septic shock have positive blood cultures, and another 25% of presumed septic shock patients remain culture negative from all sites. But the good thing is that the mortality is the same between culture positive and culture negative, thereby meaning that if you have started antibiotics, whether she is culture positive or culture negative, the results will be the same. Which organisms are more common? E. coli is the maximum present in genital sepsis. We also do have group A and group B streptococcus, staphylococcus, and gram-negative. Gram-negative is more than gram-positive. Now, mostly it is polymicrobial. What should be the antimicrobial of choice? It should be locally guided according to local antibiogram, but this is the CMA's advice on antibiotic. If there is septic shock, you can go for piperacillin and tazobactam, 4.5 gram 8 hourly, or ciprofloxacin and gentamicin plus metronidazole. If you suspect group A streptococcus, then clindamycin can be added. If there's risk for methicillin-resistant Staphylococcus aureus, you can add teicoplanin or you can add linezolid. The treatment should be for 7 to 10 days. Now, one should start with broad spectrum always, covering the gram-positive, the gram-negative, and the aerobic and the anaerobic bacteria, and then finally settling down to the specific therapy based on culture sensitivity. Source identification and control of infection is another major area of managing septic shock. It should be identified rapidly. Imaging is quite often required. If there's a closed space infection, surgical drainage and evacuation of retained products. If endometritis is not responding to antibiotics, one should suspect septic pelvic thrombosis and might require heparin. Not responding to antibiotic, maybe myometrial necrosis or abscess, and early surgical intervention, maybe you have to go early recourse to hysterectomy. Necrotizing fasciitis also needs surgery, and other sources of infection like UTI, pneumonia should also be looked. Clinical evaluation plus procalcitonin for de-escalation. Now, as much important as escalation is de-escalation. Once the patient shows clinical improvement, antibiotics have been given for from 7 to 14 days, total counts have normalized, organ dysfunction is resolved, one can use procalcitonin level to decrease or stop the antibiotics. Now, antibiotics should always be given for a short course rather than a long course, and it should be guided by the procalcitonin value. Hemodynamic management has already been spoken of. Fluid management, vasoactive agents, and inotropes. It should be crystalloid, balanced crystalloid, like as said, Ringer's lactate, albumin in patients who receive large volume of crystalloids, and there's no role of starch or gelatin. Now, what is the logic of vasopressors? In addition to capillary leakage, sepsis leads to decreased adrenergic responsiveness and a pathologic imbalance between the local vasoconstrictor and vasodilator mediators. Hence, vasopressors are important. And how should it be given? In septic shock, if the MAP is less than 65 millimeter of mercury despite fluids, the first vasopressor should be norepinephrine, and that norepinephrine is the one of choice, and a target MAP should be of 65 millimeter of mercury. Now, if adequate MAP is not present, then you have to add vasopressin as the second drug as a vasopressive agent, and then consider monitoring of arterial blood pressure invasively. If there's cardiac dysfunction with persistent hyperperfusion, despite adequate volume, add dobutamine or switch to epinephrine. Now, why noradrenaline is preferred? Because it is a peripheral arterial vasoconstrictor with significantly increasing heart rate without increasing heart rate or cardiac output. Similarly, vasopressin, it restores the effectiveness of cardiac catecholamines and it increases renal perfusion by causing vasodilatation. Ventilation, we have all heard. I will just skip this topic, but these are some of the important things. For management of ARDS, there should be low tidal volume, do not overload with fluids, intermittent sedation is required, and proning for more than 12 hours is very, very helpful in sepsis. The additional supportive therapies, these are important. Systemic corticosteroids for early resolution of ongoing requirement on vasopressors. Now, if this is on the basis of the adrenal study, it is seen that patients who are on having ongoing requirement of vasopressors, they are the patient who will benefit from IV hydrocortisone given 200 milligrams per day in divided doses. Now, this cortisone will decrease the days of vasopressors and they should be commenced when the norepinephrine dose is more than 0.25 micrograms per kg per minute, at least 4 hours after initiation. Venous thromboembolic prophylaxis, the DVT risk in ICU is 10%, risk of pulmonary embolism 2 to 4%. So low molecular weight heparin is preferred versus unfractionated heparin. If it is contraindicated, then mechanical or intermittent pneumatic compression or graduate stocking can be used. Now, combined low molecular weight heparin and mechanical method have got no additional benefit and it is not recommended. Blood cells and blood products. It is always better to do restrictive versus liberal. Restrictive is when you give blood products, you give RBCs when there's less than 7, and liberal is when it's less than 10. But the transfusion trigger should be less than 7, and platelets should be transfused at less than 10,000 if there's no bleeding, and if there's high risk of bleeding, less than 20, and if there's a surgical intervention, less than 50,000. Glucose control. One should initiate insulin therapy if the blood glucose is 180 milligram on 2 consecutive occasions. The target blood glucose range should be 140 to 180. 2 hourly blood glucose initially in the ICU and the later 4 hourly. And the importance of having this target blood glucose range in 140 to 180 is because if you keep it at 110 to 140, there are repeated episodes of hypoglycemia. Both hypoglycemia and hyperglycemia and variability increase mortality. Renal replacement therapy, many patients will require dialysis. There is no difference between continuous versus intermittent, and there is no difference. There is a difference between early versus delayed, and delayed is preferred. Enteral feeding early within 72 hours if the patient is ready fit enough to have feeding. It actually maintains gut integrity, reduces inflammation, and decreases insulin resistance. Now, delivery in sepsis and septic shock, it is individualized, depends on gestational age, maternal and fetal condition. Only obstetric indication is important. Early delivery doesn't decrease mortality. Outcome, 25 to 30% will have mortality. For septic shock, it is 40 to 60%, and survivors will have decreased health-related quality of life. There is cognitive impairment and functional disability, and increased risk of preterm delivery and stillbirth. Now, coming back to a case, what happened is, the patient's sepsis 6 protocol was immediately instituted. IV digoxin was administered. She continued to deteriorate, admitted to the ICU. She was intubated, placed on inotropic support. She had cardiac arrest on day 6 postnatally. Post-mortem, E. coli isolated from abdominal wound, uterine incision, bladder, right lung, and blood. This is a case report which I've taken from one of the journals. Now, the learning lessons is, there were multiple risk factors in this particular patient. She was a primey, she had diabetes, she had recurrent UTI, she had cesarean section. There was history of antibiotic use within preceding 2 weeks prior to admission. Rapid progression to septic shock in 24 hours after symptoms of infection. Inadequate assessment and failure to recognize sepsis early was the cause of mortality, and there was a delay in receiving treatment. To summarize, sepsis and septic shock are medical emergencies. Treatment and resuscitation should begin immediately and simultaneously. Early recognition of septic shock is very important. Start fluid early and then follow it by inotropes. See whether the patient is fluid responsive or not. If she is not fluid responsive, she will require inotropes. The 1 hour rule for antibiotic and drawing cultures is very important. Serum lactate levels have to be done and have to be brought down. Early source control as soon as possible is important, and delivery is by obstetric indications. Thank you so much. And this is the sepsis 6. Oxygen, blood cultures, antibiotic, fluid challenge, lactate, and urine output.
Thank you, Dr. Jhanna, for an excellent and elaborate presentation. Indeed, very well done. Just to emphasize, I would like to say the 1 hour bundle should be initiated within first hour of the recognition, and the management of the sepsis during pregnancy should follow the same basic principles as that of in the non-pregnant woman. That is early recognition, a high index of suspicion, then timely broad spectrum antibiotics, IV fluid therapy, and the source control. Thank you, Dr. Jharna.
We are having one question for Sangeeta ma'am. Why Maxelf use is controversial, although it is the drug of choice for preeclampsia, just because it causes pulmonary edema?
Yes, magnesium sulfate use significantly contributes to pulmonary edema. So that is why its use is curtailed in cases of pulmonary edema. However, in case there are some researchers who have used it in where they have restricted the volume with which they have, or one can use a intramuscular regime, what we do usually in our setting, because most of the people in the Western world are using the Zeuspan regime, where it is given in as an IV infusion.
Thank you, ma'am. And I invite Pratima Mittal ma'am for giving the concluding remarks.
Thank you, Nalini. I think it's both of them, Dr. Sangeeta and even Dr. Jharna, both of them have given a very, very important, take-home messages. And especially when we talk, Dr. Sangeeta's talk, if you look at it, everything, have to always think of prevention, prediction, and problem solving. So prevention and prediction are very, very important, which have to be taken care of. Then only we can really manage the complications. And as Dr. Sangeeta was talking about, the cerebral complications, I have seen that the press is very common, and those things. So everybody should keep in mind, knowing these complications, that we have to get the investigations according to these, in problems which are known to occur in severe preeclampsia, and of course manage them as early as possible. And Dr. Sangeeta has beautifully explained it, and Dr. Jharna has very beautifully talked about the sepsis bundle. I think this Taru has already pointed out these 6 points in the beginning, measuring lactate levels, giving oxygen, fluid therapy. I think that is the core important thing which have to be really highlighted. And every student, every postgraduate student should know how to manage a case of septic shock and how to manage a case of severe preeclampsia. So these must be incurred into them. And I always advocate that you put these charts, management of these important conditions, as charts in the labor room, in the critical area, in the emergency room, and keep on reinforcing that the postgraduate students are really following these protocols which are really advocated for preventing these complications. Thank you.
Thank you, ma'am, for your these very nice comments. They, in a nutshell, you have summarized all that has been spoken in these 2 talks. And now we move on to the 3rd session of this program today, that will cover medical disorders in pregnancy that give rise to indirect maternal mortality. And I will call upon the chairpersons, Dr. Anjali Tempe. Madam is the senior most faculty member of Department of Obs Gynae at Maulana Azad Medical College. She is Director Professor, Unit in Charge, IVF in Charge. She has been working here since the past 31 years with vast experience. She is a Delhi State Awardee for her distinguished services to distinguished medical services and many publications. She has co-edited 5 books, and she has held many important posts in various organizations in the past. Next chairperson is Dr. Achila Batra. I think she is one of the most familiar face in Obs Gynae in Delhi at the moment. Madam is the president AOGD. She has also been president NARCHI Delhi chapter previously. She is chairperson of several other committees. She has been a dedicated PG and UG teacher for the past 35 years at Subvising Hospital. And she has conducted several research projects, authors books, and there are many other contributions which cannot be spoken in such a brief time. Next chairperson is Dr. J.V. Sharma. He is also a very well-known figure among obstetrician gynecologists of Delhi and country as a whole. He is working as a professor at AIIMS, New Delhi. Previously, he was in our department at Maulana Azad Medical College. He has also worked in UK for 4 years. He has been awarded the most prestigious BC Roy Award by our President of India for his research work in Obs Gynae. His publication runs not into some tens, they are in hundreds. He's authored several textbooks and edited others also. And so we'll look forward to hearing from them. And now I will request our chairperson, Dr. Anjali Tempe, to introduce Dr. Tasneem Pirani, who is our star, I can say, faculty today from London.
Is she there? I can see her. Good
Yes,
afternoon.
ma'am, she's there.
I can't see her.
She's there. I can.
Hi.
Good afternoon.
So good afternoon. I would have liked to see her face while introducing her. So as you have already listened, you have discussed the direct causes of maternal mortality and the complications arising out of it. So we now have a session where there are indirect causes of death, and which are very, very commonly seen in our country, as the medical disorders have not been controlled or the cause is yet not known. So here we have two discussions on one by eminent speaker on liver failure and hepatic encephalopathy in pregnancy. So Dr. Tasneem, let me introduce Dr. Tasneem Pirani. Good afternoon. I can't see
Good
her.
afternoon. Good afternoon. I'm here.
So you are, how I would have asked you how you are connected, because to India, you did your MBBS, or this is not written. The introduction mentions only graduated from Imperial College School of Medicine. So are you connected with India in some way?
No, apart from my mum. My mum is Indian. She was born in Mumbai, and I have some family out there, but I don't have a direct connection apart from the fact that we work with a lot of the liver intensivists in India.
So subsequently,
Thank you very much, Tasneem, for accepting my invitation. This is Ranjana Sharma here.
Hi.
Hi. Thank you very much. And we were really waiting for you for your lecture. Thank you.
She has a connection to India, so later I thought she is MBBS from here. That was not written, so it is graduated from Imperial College London, and she has subsequently took posts in various hospitals in London, and now she is a clinical lead and consultant at the world-renowned liver intensive therapy unit at King's College Hospital, and must have done a lot of research about which it is not written, but her special interests include pregnancy with acute liver failure, critical illness in the context of hematological malignancies, etc. And also super specialized, I would say, region of extracorporeal support and things like that. So obviously, Dr. Tasneem, I would have questions regarding this in pregnancy. How do you manage? So I would like everybody to intently listen to this talk, since we have a lot of liver failures in pregnancy and the patients die. So over to you, Dr. Tasneem, for your lecture on acute hepatic failure / hepatic encephalopathy in pregnancy. Over to you.
Wonderful. Listen, thank you all so much for such a warm welcome. It's absolutely delightful to be here. I'm so honored to be invited, surrounded by all of you eminent people. And can I just say what an amazing session this is. I think that, understanding where your maternal mortality lies, what the causes are, and trying to tackle this by educating really has to be one of the best things that's going on for you. So, delighted. Now, a very kind introduction, and I sort of want to just give you a preamble and say that I can't really talk about hepatic encephalopathy without going into acute liver failure. I have a background in hepatology. That was my training. I trained in intensive care. So I'm going to try and combine the two together to give you a flavor for liver failure in the context of pregnancy. So bear with me if we run over time just a little bit, but I'll try and make it as interesting as I possibly can. Now, in terms of conflicts of interest, now this is London, this is where I have trained, and I am very, very fortunate in that we're part of a national health system. So certainly Dr. Sharma here, who has worked in England, you know that for whatever problems we have with the NHS, it's an amazing healthcare system. It's free at the point of delivery, and it delivers some really world-class treatment. So this is a conflict of interest because obviously I haven't practiced in India. And, although I can read about all of the challenges of healthcare systems outside of England, I really can't be the person who's an expert in that. So I'm very fortunate for the kind of training and background that I have. And the other conflict of interest is that, of course, I come from King's College Hospital, which is synonymous with liver disease. I work on the liver intensive care, where a lot of the publications around management of critically ill liver patients, including pregnant liver patients, comes from. So I live in a legacy whereby some of the treatments or kind of propositions I have may be very good to manifest within the context that I work in, and may be very difficult to implement outside of the work that I do. So I'll give you some pointers as to where I think these opportunities could come from. Now, by way of introduction to liver derangement in pregnancy, it's important to categorize this to some extent. Now, you all know that there are normal physiological changes that occur during pregnancy, where you will see some sort of liver enzyme abnormalities. You'll see often later on in pregnancy, the ALP will rise, and this is because of placental production of ALP. The albumin goes down because of dilutional effects, and these are normal changes. And it's trying to be careful to recognize where you've moved from physiological to pathological changes. Up on the top of that screen, you will see that there are certain liver diseases that are unique to pregnancy. If you are not pregnant, you're not going to get these problems. Those highlighted in blue are associated with hypertensive disorders of pregnancy, and acute fatty liver of pregnancy is another one which can cause acute liver failure, and we need to be vigilant about that. At the bottom of the slide, there are abnormal liver enzymes that can occur either in the context of somebody having underlying liver disease, and you may know about it or you may not know about it. And this is where good antenatal care, good follow-up in hepatological clinics allows you to have some context as obstetricians as to people who may develop complications. So for example, patients with cirrhosis and portal hypertension, usually around the second trimester, you're starting to worry about deterioration in the portal hypertension. And on the other hand, you can develop liver diseases that are completely unrelated to pregnancy. You happen to be pregnant and you develop these. And so this could be gallstone diseases, sepsis that's very specific to the developing world, like dengue fever, malaria, and leptospirosis. But there again, I've highlighted the three causes that can well and truly lead to acute liver failure and a progression. And one has to think about whether pregnancy itself puts them in a higher risk of developing worse liver failure. Now, before we move ahead, it's important to have some idea of what do I mean by acute liver failure. Now, over the years, the definition of acute liver failure has been really finessed. And this is the definition that's widely acceptable. And certainly when it comes to that 4-week duration here, this is the definition that's very specific to India. So acute liver failure is a clinical presentation of encephalopathy, jaundice, that's associated with a coagulopathy. So a patient who develops an INR that's more than 1.5 has jaundice and encephalopathy, by definition has acute liver failure. Now remember that these patients must not have liver disease to begin with. So if they have underlying cirrhosis or chronic hepatitis B, then actually this is more of an acute on chronic. And in India, the sort of diseases that present with acute liver failure usually manifest within 4 weeks. So we say that the 4-week duration. In England, on the other hand, we subcategorize. So we have hyperacute, acute, subacute, and this could go on from 0 to 7 days, 7 days to a month to 3 months down the line. So very different definitions, but this is the acceptable one for you. If a patient does not develop encephalopathy and just has jaundice and coagulopathy, this is not acute liver failure. This is acute liver injury. And it's very important to distinguish between the two because they have prognostic values. Acute liver injury has a much better prognosis than those that develop encephalopathy and acute liver failure. In terms to trying to determine what causes acute liver failure, you can see that in the East and other parts of the developing world, hepatitis E is the most common cause of acute liver failure, whereas in the West, in England, and certainly in the US also, paracetamol overdose tends to be the commonest cause. And often the data about acute liver failure has been sort of scrutinized, and people have said, well, can you really translate those populations with acute paracetamol overdose to those who develop acute liver failure from other causes? And I'll try and explain why, yes, you can extrapolate some of the data. When we look at acute liver failure in pregnancy specifically, and this is data from the US study group in acute liver failure, and this very much mimics the practice in the UK. 3,200 patients, and you can see 70 of them were acute liver failure in pregnancy. So that makes up about 2% of all of the cases. And you can see here that the commonest cause of acute liver failure in the West is pregnancy-specific liver diseases. So that's acute fatty liver of pregnancy and HELLP syndrome, and then closely followed by paracetamol overdose. And you can see there on the right-hand side, there were 0 cases of viral hepatitis. So nobody with hepatitis A to E. A few cases of herpes simplex related hepatitis, but no viral hepatitis, which is very interesting. And when we look at the outcomes of these patients, where I have circled in red there, we normally in liver failure try and talk about transplant-free survival and overall survival. So in those patients with pregnancy-related acute liver failure, there was an overall survival of 82% and a transplant-free survival of 78%. So if they were only managed medically, 78% of them got better. And that's important to know, because if you are in a system where transplantation is not as readily available, it's good to know that over 75% of these patients will survive. And then you may think, well, actually, maybe they were not that sick to begin with. And that's not true, because if you look at that turquoise bar there, 54% of these patients had high-grade hepatic encephalopathy, very similar to hepatitis A, hepatitis B, paracetamol overdose. So why is it that their survival is better, whereas in hepatitis B, the transplant-free survival was only 19%, and they were similarly as unwell, which shows that the outcomes are not purely related to hepatic encephalopathy, and the underlying etiology also has a part to play in mortality determination. Now, we in the UK collect all of our data through a national audit program called the Embrace UK program, where every so often we get a UK confidential inquiry into maternal deaths. And this is data from 2015 to 17. And you can see there that 9 women out of 100,000 live births died during pregnancy. So that's our maternal mortality rate. And I compare that to the ones in India, which is through a publication just there on the right-hand side. And I know that Dr. Gupta has already talked about the great work that's gone into trying to reduce the maternal mortality rate, but it's really nice to put a spotlight into what's causing these mortalities. You can see in the UK that preeclampsia accounts for only 2% of the mortality, and liver failure does not feature on there, and hence maybe we don't have that much of a spotlight on liver failure in pregnancy. Whereas when you look at your Indian data, and this is lovely kind of data from Dr. Goswami's group and another group where they looked at post-mortem data, as you've heard time and time again, the indirect causes are predominantly related to hepatitis, and there are high causes in the direct causes related to hypertensive disorders, which can also affect the liver. So putting a spotlight on this at this period seems like the most appropriate thing to do. Now, I want to go specifically into hepatitis E, because this is the commonest cause of acute liver failure in Southeast Asia, in India, in Bangladesh. And we try and see what's going on in pregnancy with hepatitis E. The most fascinating thing is that if a pregnant woman develops hepatitis E, she's 13 times more likely to develop acute liver failure as a result of this. And the mortality associated with this is anywhere between 50 to 75%, so high mortality. So you think, well, why is it that hepatitis E affects pregnant women in this way? And there's been a lot of theories postulated, and I don't think we've really honed down the exact reasons. But the risk factors are thought to be sarcopenia and a reduced body mass index, and particularly nutritional deficiencies. And this is where poverty and lack of nutrition would come into this picture. All pregnant women have a change in their sex hormone profiles and a change in the way in which their immunity works. So they have a reduced macrophage activation. They move more from T helper cell 1 immunity to T helper cell 2 immunity. And this is all in preparation to protect their baby. But by doing that, they might be making themselves more susceptible to hepatitis E. So pregnant women are well and truly at risk of Hep E. But the other interesting thing is that they have a very short prodrome. So by the time they feel unwell and generally not great, they progress rapidly. And in my opinion, I think a lot of them present to healthcare services quite late in established multi-organ failure. So you sort of had no real window to intervene in good time. And remember, in India, you're also battling with the fact that there are other risks like typhoid, leptospirosis, dengue fever, all of which can have overlapping symptoms and pathophysiology, which makes it quite difficult to understand. Am I dealing with hepatitis E and liver failure? Am I dealing with an infection that I can just treat with antibiotics? And I come back to the fact that there are certain things in the background that we can't ignore, which is the hygiene, the hyperendemic situation with hepatitis E in India, education, both for clinicians and the patients about trying to get medical attention early, poverty, and lack of healthcare services. Now, when we talk about the adverse outcomes due to acute liver failure, of course, hepatic encephalopathy is one of them, because hepatic encephalopathy can very quickly develop into cerebral edema and cause cerebral herniation. And this is thought to be the case in 20 to 30% of acute liver failure patients. But majority of the patients don't die of hepatic encephalopathy. They die of multi-organ failure. And you can see on the cartoon on the right-hand side, acute liver failure can affect every single organ in the body. And if a patient presents very late in the course of their disease, then it becomes really, really difficult to get on top of this multi-organ failure. I've touched briefly on the fact that etiology also matters. So it depends on what your underlying etiology is. Hepatitis B, for example, very few have a transplant-free survival, whereas there are things like pregnancy-specific liver disease, where once you've delivered the baby and you've looked after them in a right environment, they should all get better very quickly. To define encephalopathy is very important, because what it is a brain dysfunction that's caused by liver insufficiency. And that's really where you need to stop. The portal systemic shunting is more relevant to those patients with cirrhosis, where they've developed multiple collaterals in the context of a stiff liver. But when it comes to acute liver failure, we're talking about the fact that the liver just cannot cope with the toxin load, and you then have toxins that go into the systemic circulation and affect the brain. And it can manifest in a wide variety of neurological and psychiatric manners. And this is where it starts to become complicated, because the manifestation is not specific. The same kind of manifestations you could see with somebody with a brain tumor or a stroke or hypoglycemia. And this is where it starts to become complicated. It's considered as a metabolic phenomenon, and I put there that it's reversible, and I put some question marks there, because actually, if they present to you with established cerebral edema, established intracranial hypertension and associated complication, then unfortunately, this is not reversible, and it's not even reversible with a liver transplant. So the reversibility is very much dependent on detecting this early and intervening early. Now, this is a really busy slide, and I don't really want you to look at all of that detail in there. The thing I want you to know that the West Haven criteria is the most recognized criteria for grading encephalopathy, but it's a really tricky one. When patients have minimal or grade 1 encephalopathy, it's really difficult to diagnose, especially if you've never met the patient before. You might put this down to a personality problem. They may be a little bit vague, they may look a little anxious, and unless you've spoken to the family and taken a good history, you may not realize that they are already developing hepatic encephalopathy. Of course, at the higher grades of encephalopathy, it's going to become very obvious because they're going to be comatose, they're going to be displaying inappropriate behavior, and it becomes very obvious. But the reason I say we need to know about the low grades of encephalopathy is because the development or the rapidity of development of high-grade encephalopathy is a certain problem. And the higher the grade of encephalopathy, the increased chances of intracranial hypertension. So we do need to detect it early. If we're only going to use GCS to describe encephalopathy, then we might be a little bit late in realizing when encephalopathy has progressed further. But of course, for simplicity of things, it's much easier to describe your patient as having a lower GCS, and everybody understands that this is related to something going on with the brain. Now, in terms of presentation, it's just things to kind of get you started as to when to think about encephalopathy. You may make excuses for your patients and say, well, they've not been very well, they haven't slept very much, this is why they look a little bit tired. But in these patients, sleepiness may be a sign of them developing low-grade encephalopathy. Speak to the family. Ask them whether they think that that member of family, that wife of theirs or their daughter, is a little bit vague and inappropriate. This may also be an indication of encephalopathy. Please try and avoid giving any of these patients any medications such as opioids or benzodiazepines to calm them down, calm their anxieties, because what you might add to this is an overlay of complexities where you don't know whether it's what you've given them that's caused them to change in behavior or actually underlying encephalopathy. By the time they start to develop signs and symptoms like hyperreflexia, clonus, seizures, they've already got brain edema, and you need to be thinking really fast about where to manage these patients. These patients ideally need to be managed in a high dependency area or an ICU. And throughout the time while you're looking for hepatic encephalopathy, also look out for signs and symptoms of multi-organ failure. And this could start off with gently a little bit of tachycardia, then hypotension and other manifestations like renal dysfunction. And this slide purely says one thing to you, that while you've got one thing on your mind, somebody with deranged liver enzymes, they're developing an altered sensorium, don't forget that other diagnoses also need to be taken into consideration. Your patient with liver failure may well develop hypoglycemia because they have no ability to generate glucose from their liver. Make sure you check their glucose and make sure that you optimize glucose, because a combination of neuroglycopenia and hepatic encephalopathy really will add to an adverse outcome. This one slide really just wants to give you just some pathophysiology about hepatic encephalopathy. There are many postulated sort of theories about what causes the progression from encephalopathy to cerebral edema. And the common thing to all of this is ammonia. So ammonia is produced in your bowel. So your colonic bacteria will break down protein to produce ammonia. The ammonia normally goes through your liver, is broken down in the urea cycle to urea. You then pass you then get rid of the urea through the kidneys. In liver failure, on the other hand, you no longer have the ability to get rid of the ammonia. And so ammonia now goes unchanged across the blood-brain barrier into the brain. The ammonia is then converted into glutamine in the brain, which is taken up by the astrocytes, which is the most common brain cells in your brain. And the glutamine then attracts a lot of fluid to be sucked into the astrocytes. So your astrocytes start to get more and more swollen. So we call this cytotoxic brain edema. There are many other causes of brain edema and worsening in hepatic encephalopathy, like vasogenic edema, which is where the blood-brain barrier is affected by inflammatory mediators, impaired autoregulation. And I'm not going to go into that, but really to point out that ammonia is a real key player in this. There's been a lot of studies to look at the thresholds for ammonia to try and determine, is there an ammonia level at which I know that a patient is at risk? And in India, this was a study of 80 patients done in the sort of early 2000s that said that, well, the cutoff level of about 124 millimoles was highly predictive for mortality because about 52% of these patients were dead. There have been numerous other studies, and this is a study done at my institution, where we found that actually when you have an ammonia of more than 100 micromoles per liter, it definitely predicts higher grades of hepatic encephalopathy. And certainly over 200, then you're at high risk of intracranial hypertension. But there's a big overlap here. This is a very sort of specific number, 200, but it doesn't have sensitivities because there are some patients who could develop intracranial hypertension even with lower numbers of ammonia. So although ammonia is an independent risk factor for hepatic encephalopathy, there are other risks. And our study showed that the younger the patient, such as childbearing age women, have obviously a nice, juicy, big brain that hasn't atrophied with age. If they develop renal impairments, sepsis, a SIRS-like reaction, or need vasopressors, then the risk of hepatic encephalopathy becomes much higher. And in that situation, an ammonia of just 100 may be enough to progress to really high-grade hepatic encephalopathy and adverse outcomes. I might just skip this slide because I've sort of talked about it, where we've moved from compensated to decompensated cerebral edema. Now you may say, well, okay, ammonia is a bad thing, young age is a bad thing, sepsis is a bad thing. How are we going to manage that? Now, this is a really nice review that we did from our experience of acute liver failure patients in 3,300 patients over 35 years. And the graph on the left-hand side there shows that in about 1,500 of our patients, we saw that with time, the signs of intracranial hypertension has gotten better. Okay, so this is despite the patients coming with acute liver failure, the signs of intracranial hypertension is improving, and the survival in those patients with high-grade hepatic encephalopathy is also improving. And why is that the case? And the case is because we are publishing a lot more, and this is worldwide, universally. And at the bottom there, I want to point you out to the Indian guidance on management of acute liver failure. And all of the guidance will now talk about earlier neurocritical care monitoring and interventions. And a lot of these interventions have been borrowed from neurocritical care. So when I talk about neurocritical care, I talk about those patients in ICU for problems that are not medical, but more related to traumatic brain injury, strokes, etc. So there's a lot of borrowing of information from these groups. And the focus of the management starts off by excluding all of the causes of neurological disturbance. And we talked about that earlier, things like electrolyte disturbances, hypoglycemia. Then dealing with ammonia, because we know that ammonia is really highly implicated in hepatic encephalopathy. Aggressive management of multi-organ failure, because we know that ammonia alone is not the full picture, but that multi-organ failure can also lead to adverse outcomes. And then adoption of a bundle of neuroprotective intervention. And the reason I call it a bundle, because there's not one specific intervention that will improve mortality. The interventions need to be taken all together, and it's the totality of these interventions that's important. And you need to initiate appropriate monitoring in the correct environment. We know from Dr. Goswami's reviews that a lot of the mortalities occurred in medical wards, and we now really highly promote that patients are admitted to a high dependency or critical care area first. And the other thing not to forget is that we need to be working within an MDT to recognize when transplantation is the only intervention that's going to help in survival here. You may do whatever you want in your ICU, you may pick the best bundle, but there are some patients that you need to know through experience of hepatologists when transplantation is the only way forward. One of the ways of reducing ammonia is to try and reduce the production of ammonia. In acute liver failure, this is all very pointless. So you've probably heard of lactulose, antibiotics, Lola. None of this works in acute liver failure. So we're going to ignore that. What we try and do is we try and clear the ammonia. And the way in which we do that is by providing continuous veno-venous hemofiltration in the ICU. Now, in the West, we've probably been slightly ahead of the game in this scenario because actually in the West, the incidence of renal failure and acute liver failure is about 50 to 60%. So a lot of our patients ended up on filtration much sooner anyway. In India, however, the data suggests that there's less than 10% that develop acute kidney failure. So it's possible that this is the reason why they don't end up on the filter. But we now know that ending up with hemofiltration is also useful for ammonia clearance. Of course, needing to go on the filter is also a very expensive intervention. Plasma exchange has been used throughout medicine for many years for a lot of autoimmune conditions, where you replace the patient's plasma with either fresh frozen plasma or albumin on a 1-to-1 ratio. And the idea here is that you're trying to get rid of various different putative molecules or plasma-derived factors that either compound hepatic encephalopathy or reduce the ability for the liver to regenerate. And there was a big trial in Europe that was published in 2016 that showed that it also had a mortality benefit in acute liver failure. So those patients who weren't able to have transplantation, if given plasma exchange, had a better outcome than those that didn't have plasma exchange. So that's another way of treating hepatic encephalopathy and worsening acute liver failure. And then this is the bundle that I'm talking about. And I'm not going to go into every single step, but what I'm trying to say here is that once your patient develops high-grade hepatic encephalopathy, they do need to be admitted to an ICU or HDU environment. And once they develop grade 3 to 4 hepatic encephalopathy, they're becoming very combative. These patients should be intubated and ventilated for cerebral protection. What you're trying to do there is promote good cerebral perfusion pressures. You're trying to reduce intracranial pressures by reducing the cerebral metabolic demands, and you're adopting various different things. So you're trying to increase their sodium levels to 145 to 150 to try and reduce the edema. You're maintaining a glucose infusion to avoid episodes of hypoglycemia, which can be compounded in the context of hepatic encephalopathy. You are on the hunt for sepsis and inflammation. And certainly in my institution, we do use prophylactic antibiotics because it's very hard to decide when a patient is developing sepsis when they're so inflamed with acute liver failure. We know that sepsis does worsen hepatic encephalopathy, and by virtue of that, we'll be increasing cerebral edema also. We take an ABCDE approach, and we intervene or get the MDT involvement early. The thing that has changed in the last 10 years, certainly of management of acute liver failure, is that there's an early discussion with an MDT and an early transfer to a specialist center. The other thing that is absolutely vital is to start determining at the outset whether the patient will survive without a transplant. So like I said earlier, you can do all of these nice things to try and get rid of ammonia, treat the sepsis, admit them to an ICU, but there's some people in whom survival is not going to happen unless they have emergency liver transplantation. And throughout the years, there have been criteria that have been developed to try and predict patients who will not survive. The most popular being the King's College criteria for poor prognosis. Now in India, they say that this criteria is not particularly sensitive or specific for their population, but still widely used. They have other criteria, so the Alfred model, etc., which is more specific to India. But the important thing to know that all of these criteria were developed without pregnancy included into that. Okay, so if your patient comes with pregnancy-specific acute liver failure, then this really is an MDT discussion. When do you deliver the baby? What criteria are you going to use to determine that this patient is not regenerating the liver in good time and they actually need liver transplantation? And this is data from King's College, my institution, that showed that patients who are, with pregnancy-specific liver disease who present with a high lactate and encephalopathy that does not get better are at higher risk of not recovering eventually. And you'll be glad to know that this is my final slide. And this is really a summary of what I've been trying to say, that management of acute liver failure, hepatic encephalopathy really starts from the public health initiatives and goes all the way down to bespoke management for the individual patient. When it comes to right at the beginning, educating clinicians as you are today, public health interventions to try and ensure that antenatal care and screening for underlying liver diseases, improving nutrition and vitamin supplementation in women may reduce their risk of developing liver failure in the first instance. Once they start to get derangement of their liver enzymes, then you need to have a high index of suspicion that they are now entering acute liver failure. A detailed history and a detailed hunt for etiology is absolutely vital because the prognosis is dependent on that, and make sure to regularly assess them. As soon as they start to develop any grade of encephalopathy, you want to transfer them early to an appropriate environment. Great degrees of encephalopathy need to be intervened on by endotracheal intubation. Don't forget to look at their glucose. And then developing a bundle of interventions. I think one of your colleagues earlier says, just make sure that you've got posters around your units to say that this is the bundle of interventions we are going to undertake in everybody who comes to us with acute liver failure. Please remember that young patients with renal dysfunction and hemodynamic compromise are at worst risk of developing worsening hepatic encephalopathy. And please look to your international societies and local guidance for guidance that's really specific to your patients. Thank you very much.
Thank you, Dr. Tasneem. It was really an eye-opener. However, I'm going to ask you first thing, what is the development, recent development in the context of, antivirals in hepatic E virus, hepatitis E virus, and its any role of antiviral?
So there is a role. I mean, the role is controversial. Ribavirin can be started. The issue really comes to the fact that if we're looking at pregnant women particularly, and by the time you've reached the point of acute liver failure, unfortunately, the benefits of introducing antivirals start to become less clear. And the treatment is well and truly around supportive management in these patients. You know, even when they have delivered, so there's been data around termination of pregnancy earlier because it's felt that there is vertical transmission of hepatitis E into the baby. And when you've got the baby out, actually the baby's got hepatitis E. And the two individuals are perpetuating the whole process. So regarding specifically on antivirals, you know, it's neither here nor there. Of course, if we had a brilliant vaccine, that would be amazing. Improvement in hygiene and understanding how not to get hepatitis E in the first place would be the trick here, really.
Yes, so I fully agree with you that the social environment and the poverty and hygiene, particularly if we prevent. So prevention has a bigger role than actual treatment. And unfortunately in India, there are not many liver transplants, as you already have discussed. You don't have hepatitis E in your center at all. That is what I got to know.
Well, so we had one hepatitis E recently, you know, and this was in an adult male with cirrhosis. So that's another group in whom it's worse. But no, we haven't seen that many in pregnancy, certainly in the last, 2 decades, really.
And one more question, this is a small question. Hepatitis B failure, liver failure, how many percentages of acute liver failure or chronic liver failure in pregnancy? Because we also have hepatitis B as a next common factor to deal with hepatitis with pregnancy. So what's your take on that?
So my take on it is, it's of course, it's a risk factor. the point about antenatal screening, and I don't know what they do in India, but one of the tests that we do as part of our antenatal screening is that everybody has a hemoglobinopathy screen. They have an HIV screen and hepatitis B screen during antenatal. So you know those patients in whom they already have chronic hepatitis B. We don't see that many, if you like, acute hepatitis B in pregnancy because they have such good antenatal care. But we have seen cases where you've had, if you like, a flare of their underlying hepatitis B. And a lot of our patients, or actually all of our patients with underlying hepatitis B, are plugged in with hepatological services who monitor their hepatitis B DNA levels very closely and initiate treatment towards the end of pregnancy, really with the aim not to prevent a flare, but with the aim to reduce vertical transmission of Hep B. So in terms of my experience with that, I would say, so in the last 10 years, in pregnancy, I've had one patient with a flare of acute hepatitis B.
So definitely the prevention is
like a fraud, because obviously the diseases we're dealing with are so different to the ones you deal with.
Yeah, Dr. Tasneem, what an excellent and authoritative talk by you. Really, very informative.
Thank you.
My just one last question to you, Tasneem. I mean, we have these hepatitis E patients going into hepatic encephalopathy. I recently had a gynecologist herself. She was a consultant gynecologist going into failure. And, I was delivering her, and then she was bleeding from everywhere. And then she told me, just pack me. She was aware of things, and ultimately, unfortunately, we lost her. But our hepatologists always tell us when we get these patients, they just deliver them, they will improve. And then in such a condition, we don't want to induce them. Actually, what is your take on that?
Yeah, it's a really tricky one. And, this is not me trying to pass the buck. We really believe in the MDT approach here. So it's very straightforward in my mind. If a patient with pregnancy-specific liver disease, so acute fatty liver of pregnancy HELP syndrome, if they present with acute liver failure, delivery of the baby is the only thing that's going to cure the patient. So that in my mind is clear cut. When a patient presents with an other cause of liver failure, then it becomes very tricky, because if you intervene early, so if you try and deliver the baby early, then you run the risk that you could cause maternal decompensation further, okay, in which case you don't know whether it was the delivery that induced that or whether they were going to get worse anyway. So we take a real considered decision. So I can only tell you about in the last 10 years, the one patient with the flare of acute hepatitis B that we had. In this patient, what we did, and again, we are very lucky, we listed her for transplantation. And once we knew that she was on the transplant list, we made a decision that we would only deliver the baby in the context of transplantation. Because if your cesarean then ended up causing a decompensation further and making the mother more unstable, at least you had liver transplantation as your get out option. So I think it's really tricky in India where, transplantation is not readily available. We have to be cognizant of that. We also have to recognize that, all of the things that I've told you about dialysis and ICUs, it's an expensive business, and not all of these young women are going to be able to afford that. So in that context, I think taking the most considered, thinking that, well, actually, if it's hepatitis E and the fetus, it's later on in pregnancy, and there's a high chance that there's already been vertical transmission to the fetus, and what's driving the process is fetal hepatitis E, then considering delivery at that point. But of course, the coagulopathy and the complications, it's incredibly difficult to manage that.
Thank you very much. And this Chinese vaccine of hepatitis E, I mean, it's not available in India, but your take on that?
Yeah, so it's not, I don't think we have it either, but I was actually reading about it in the context of Hep E. I think that it's definitely where the investment needs to be. It's a real shame. And we know that these investments can occur. Look at COVID. We've managed to get vaccines for COVID in half a year. So I think it's important to invest in those for sure.
Thank you. Really excellent talk. Thank you.
Thank you.
Thank you very much, Achala. Please, over to you.
Yeah, thank you, Dr. Anjali, and thank you, Tasneem, for an excellent overview. And but our questions still remain answered. What to do with the hepatitis E patients? But what I personally feel is that if the baby is viable, say 37 weeks, and the mother is deteriorating, maybe just save the baby probably. But it's a very individual decision, and we still are we don't know what to do. Anyway, it was a very good talk. A lot of things we have learned. Maybe we are not able to do it now. Later on, maybe we'll be able to do. So it's good to know that all these things are available. But definitely, we can maintain the oxygen saturation. We can maintain the intracranial MAP and give oxygen. So that can be done. So now, after this wonderful talk, we have another very, very important talk by a great person, Dr. Mohit. Dr. Mohit is a fellow of not only, Indian Society, but also of European, American, as well as Royal College of Physicians, Edinburgh. And he's had 18 gold medals, 5 silver medals, many books, many publications. And he's a professor of cardiology in GB Pant, and he's medical superintendent of cardiac disease. And he's going to talk about peripartum cardiomyopathy, something, again, we are having a lot of patients with peripartum now. Maybe we are diagnosing them more. Probably we always had them. But we are getting a lot of patients whom we pick up fast, and they need treatment. And we also need the help of our cardiologist friends. And to know exactly how they have to be managed, we have with us Dr. Mohit. So Dr. Mohit, over to you.
Hello, friends. Thank you for this great opportunity and welcome to this wonderful conference. I'll be speaking on critical care in pregnant cardiac patients, a case-based approach. So let me get you rolling. Managing pregnancy and heart disease is like driving on a very difficult terrain. It's not easy, especially when you are already overloaded with hemodynamics and pregnancy further complicating the situation. It is really troublesome. You really have to be very, very gentle and very careful when you are driving on this terrain. And let me tell you why. Let me take you through these eyes, because pregnancy is complicated by maternal disease in 1 to 4% of cases. And most common cardiac complications are arrhythmias and heart failures, and especially so in middle and low group income countries, especially in comparison to the maternal cardiac comorbidities, common depending on the population study, and almost 5 to 20% of the pregnancies in women are occurring in those with heart disease. We need to know a couple of important physiological points that underlie this hemodynamics. There are significant cardiovascular changes that are occurring in pregnancy. We all know that during pregnancy, the plasma flow is increasing, and also the cardiac output is increasing by almost 30 to 50%. The systemic and the pulmonary vascular resistance decreases significantly. In labor, this further complicates by increasing of cardiac output by 30% in active stage of labor, and the circulating blood volume increases almost by half a liter. So it's all really troublesome. And now you see the cardiac output is increasing in the third trimester, ending of the second trimester, and third trimester keeps on increasing during the labor. And it's only the postpartum period early that it is starting to get normalized. So we all must understand that these are really complex situations and require a very delicate hemodynamic approach. What are the general recommendations? I'm not going to go into the details, but one thing is sure, that managing pregnancy in patients with heart disease requires a complete heart team approach. No single person can actually do it, and it requires a proper evaluation. What are the WHO guidelines and classification for maternal cardiovascular risk? There have been 4 classes that have been outlined, and let me take you to the most relevant ones in which it is really contraindicated or it's really very high risk. Both the cases that we'll be discussing today. Look at this. Those with PH should not undergo. They have a very high mortality, maternal mortality risk, approaching almost 40 to 100%. Those patients with ejection fraction less than 30%, with peripartum cardiomyopathy with a residual left ventricular impairment, those with left heart obstructions, valvular obstructions like mitral stenosis, like significant symptomatic aortic stenosis, these are the cases that are really troublesome. Those with recoarctation, fontans, all these are further cases, but these are the common conditions that we encounter in our clinical practice. Let me take you to the first case. Look at this now. We will analyze it. We have a 34-week pregnant female into the third trimester with severe mitral stenosis. She's in class 4, pulmonary edema, atrial fibrillation with fast ventricular rate. How to approach? Now, look, 4 different scenes are occurring in this patient. We are almost into the third trimester. The patient has a significant left ventricular outflow obstruction. That means mitral stenosis is there. She is in pulmonary edema, that is congestive heart failure, further complicated by atrial arrhythmias with fast ventricular rate. Let us go step by step. Where did we go wrong? Did we know that the patient is a case of severe MS? Did we approach the cardiologist for this heart team approach? Or did we counsel the patient about the underlying risk and advised her with all the documentation taking place properly? This is the reason. This is why we need to have a very clear vision when we are approaching. Remember the same chart. A patient with class 4 edema, ventricular dysfunction 30%, or NYHA class 3 or 4 like our patient. With patient with severe mitral stenosis, all these patients have a very high maternal mortality risk, almost approaching 40 to 100%. So, no doubt, our patient is in a high risk category. Again, what are the predictors of the maternal cardiovascular events? NYHA class 3 and 4. Our patients falls in this, and left heart obstruction, moderate to severe, again, mitral stenosis. As far as the fetal risks are concerned, again, you see the heart failure and also maternal left heart obstruction are predicting the fetal events also. So this is all a reason for worry. What are the high risk features in our patient? All the patients with NYHA greater than 2, like in our case, systolic pulmonary artery pressure more than 30, again, like in our case, severe stenosis in our case, not an older age patient, not in our case, but these are risk for maternal complications. The common complications that are occurring are heart failure in almost 1/3 of the patients, especially in the second trimester. Sustained AF, our patient has it. In less than 10% patients, it will precipitate heart failure. And the maternal high mortality events, almost approaching 0 to 5%. So this is very severe. This can be really disastrous. And similarly, there are significant risks for the fetus also. So first step is, can I quantify it by a score? Do I need a score? In this particular case, you don't need a score. It's very clear. Any left heart obstruction or high risk cardiac lesion, it's a high risk case and it has to be dealt accordingly. But those patients who are not falling in this category, there are various scores that have been given, and one of them is the Preg score, which is Preg 1 and Preg 2, which calculates risk according to the different parameters, according to the high-risk cardiac lesions, according to different age and other parameters, heart failure, ventricular dysfunction, whether it's a mechanical valve, it's underlying coronary artery disease or pulmonary hypertension, all these give a score, and a particular score will predict the event. But in our case, we don't need it. We already know that we are dealing with a high-risk case. Timing of complications, our patient is already developing atrial fibrillation and pulmonary edema. Look at this, at the 28 to 40 weeks, both arrhythmias and pulmonary edema are going very high. Both of them are going very high. So our patient is in antepartum stage in this category. What am I going to do in this particular case? Do a quick planimetry to confirm your diagnosis. Have a pressure half-time method, though it is less reliable, but still it can be used. Our patient has a significant MS, there is no doubt about it. And now we have to see whether there is associated mitral regurgitation. Our patient does not have it, and our patient has a high pulmonary arterial pressure. Our aim is to immediately control first the heart rate. Beta blockers like metoprolol and bisoprolol are very good events. But if the patient is in heart failure, we are at a very, it's like a catch-22 situation that what should we be using? Then in these cases, to decrease the heart failure, we can use judiciously loop diuretics. They are very, very helpful. Further, strict activity restriction. Patient has to be in complete rest. And then anticoagulation. If the patient has an AF, our patient has developed an AF. We presume, like in this case, it's an acute onset AF or a chronic AF. Maybe it's an acute onset AF. We will see how we are going to deal it. But anticoagulation is indicated if atrial fibrillation is paroxysmal or persistent, if there is an underlying left atrial thrombosis, if there is a sinus rhythm with significant MS and spontaneous echo contrast and a large LA. All these parameters you must ask from the cardiologist or cardiac opinion when a patient of mitral stenosis presents in this particular condition. Now, if in pregnancy, how much is the concern? 27 in 1 lakh cases, it could be low, and especially more in valvular heart disease, very relevant to our country. Very, very relevant to our country. How do we manage? Let us take this case. There could be 2 situations. Our patient has been absolutely comfortable. She did not have AF, and she suddenly gets unstable heart failure because of atrial fibrillation. What would you do? I would be very happy in just shocking the patient. Do a cardioversion if you are pretty sure that the patient did not have an underlying atrial fibrillation at that time. Now, if the patient has an underlying atrial fibrillation, I would be very happy in controlling the rate. It's a great idea to control the rate. It could be if the patient is again stable, I would like to control the rate by beta blockers or digoxin. I would be using anticoagulation for the patient, very important, like warfarin, and I would cardiovert the patient pharmacologically if it is needed or hemodynamically compromised, like flecainide or sotalol. Again, the direct cardioversion can be used, but it is not very effective in a chronic atrial fibrillation. So the general principles remain that we must actually choose lenient rate control with the preferred drugs like metoprolol and bisoprolol. Ethanol must be avoided because it decreases the placental blood flow and could be very harmful. Electrical cardioversion, I just pointed out, it should always be preceded by anticoagulation. So what would I do in my case? In this 34-year-old female, if the acute onset atrial fibrillation is there, I would cardiovert the patient. Or if I'm sure that the patient had an underlying chronic atrial fibrillation and now suddenly it is compromised with a fast ventricular rate, I would just be happy in controlling the rate with digoxin or with metoprolol. These are the 2 drugs of choice. Would I anticoagulate the patient? My answer is yes. I would do it. Now, almost in 34 weeks, generally up to 34 to 36 weeks, VK, that means this vitamin K antagonist are indicated. But as I see my particular patient is approaching almost 36 weeks, I would be happy in anticoagulating the patient with low molecular weight heparin or unfractionated heparin. NOACs are contraindicated in this particular case. Look at this. A low dose VKs can be given up to 36 weeks. They have to be replaced immediately by LMWH and unfractionated heparin. And then according to the delivery plan, switch over to unfractionated heparin, then again switch over to the routine low molecular weight heparins. This is how the protocol goes. How do we intervene in this patient? That's the bottom line. My answer is do a balloon mitral valvotomy. Here is the role of cardiologists. We're routinely doing it. The results are phenomenal. The patients improve significantly, and we have great outcomes in such patients. The balloon mitral valvotomy preferably is done after 20 weeks, only in class 3 and 4, or if systolic pulmonary arterial pressure is more than 50 millimeters of mercury. Remember, closed commissuratory for mitral stenosis is an alternative in a low and middle income countries, but generally very few centers are practicing it. Open heart surgery is a rarity, should generally be avoided. I would always prefer or recommend to my patients, my gynecological obstetric colleagues, that vaginal delivery should be preferred in such patients who are in class 1 and 2 without PH. When are you going to failed PTMC? Patient has severe PH and is in persistent class 3 and 4, and there is great risk to the mother. These are the cases you prefer subjecting patients to a cesarean section, and especially routine conditions like refractory heart failure or a dilated thoracic aorta or a failed PTMC. We need to follow up these patients. A routine echocardiographic follow-up monthly or bi-monthly is very, very important for these particular patients. So just to summarize, balloon valvuloplasty mitral valve is very important. Mitral valve repair and replacement comes much later down. Most of the centers don't practice it. It's only life-saving conditions, and heart rate control with beta blockers, complete activity restriction and anticoagulation for atrial fibrillation forms the bottom line of this treatment in these patients. So my 34 to 36 weeks severe MS, do a BMV for these patients. Atrial fibrillation, if it is acute, cardiovert. If it is chronic, rate control with beta blockers, metoprolol and bisoprolol. For heart failure, use liberally diuretics, loop diuretics, and we'll be managing heart failure. I'll be showing heart failure, how it is to be managed in the next case. So this is how we approach this particular case. Now let us come to the second scene. A second scene which is a very commonly seen, that we have a patient, a pregnant female, who presents with heart failure. No underlying valvular lesion. And patient, when we investigate, has a cardiomyopathy. It could be most commonly be a dilated cardiomyopathy, like commonly we have. It could be a peripartum cardiomyopathy, or it could be a hypertrophic cardiomyopathy. These are the common conditions that we encounter besides the toxic, Takotsubo, or storage diseases, which are quite uncommon. Let me give you an overview on how do we approach these patients. A word about peripartum, you know more better than me, but remember, careful history is very important. But if EF is less than 45, it's a real matter of worry. These patients may present with heart failure secondary to LV systolic dysfunction at the end of pregnancy. And they are frequently presenting with acute heart failure and also ventricular arrhythmias. Now, this is all a great concern. If the patient has a marked LV dilatation, initial left ventricular ejection fraction is less than 30%, and there is a RV involvement, these are very poor prognostic markers in such patients. For the dilated cardiomyopathy, we must understand the prevalence is obviously, it's in the book, which is given Western literature, 1 in 2,500 patients. But remember, PPCM and dilated cardiomyopathies are distinct entities, though may have a same genetic predisposition. What is most important is answering 3 questions. What is the prognosis of my patient, number 1? What are the important drug therapies that need to be changed in these pregnancies? And how do I manage acute as well as stabilized heart failures, like in this condition that has been given to me? So which are the patients that are going to fare worse? Look at this. If a patient mother has an ejection fraction less than 20%, very poor prognosis. Mitral regurgitation further complicates. Right ventricular failure further complicates. And if you have an added atrial fibrillation, it is disastrous because you lose the atrial booster pump. The LV filling is very poor, and already compromised heart is practically non-generating output. Patient decompensates and goes into acute heart failure and hypertension. The predictor of maternal mortality are ejection fraction less than 40 and class 3 and 4. But high risk features are these features. How do you manage? Let us approach. Once you have a patient of dilated cardiomyopathy, pre-pregnancy counseling is a must because it's a very high risk feature. Maternal mortality approaching up to 40 to 100%. These patients, if they are on AC inhibitors, ARBs, ARNIs, that means angiotensin receptor and neprilysin receptor blockers, and mineralocorticoid receptor blockers, antagonists are very, very important. They should be immediately stopped. Absolutely stopped. So all AC inhibitors, ARBs, ARNIs, and MRAs are to be stopped in this particular condition. And also ivabradine. This is contraindicated in this condition. This is a commonly used list or prescribed list of those drugs that should not be used in pregnancy. We can have, this is very nicely given in the brown world. I'll leave you with this presentation. You can have this, but these are the commonly cardiac drugs that should be avoided or they should be used with caution in such patients. So what are the general principles of management? Remember, we need to differentiate with that. It's a true heart failure. It could be an uncomplicated pregnancy, pulmonary edema due to preeclampsia and eclampsia. It could be pulmonary embolism, myocardial infarction, and pneumonia. Rule out these conditions, then we are pretty sure that we are dealing with true heart failure. Use loop diuretics, but judiciously, because they decrease placental flow, but they do help in managing or in a catastrophic situations. Very important drug and underused drugs are a combination of hydralazine and nitrates. They appear safe. They are especially indicated in those pregnant patients who have a severe LV dysfunction, who have hypertension, and who have evidence of congestion and decompensated heart failure. So these are the conditions where hydralazine and nitrates are doing real good to our patients. What are the specific managements? And I'll be going to details of management of acute and chronic heart failure. A word about the PPCM, all like a typical protocol that has been given. The treatment must be continued. Even if the patient recovers from heart failure, the treatment of heart failure must be continued up to 6 to 8 months, because the moment you stop it, the patient has a very high chance of relapsing. Bromocriptine improves the left ventricular recovery and has a better clinical outcome. The doses are very standard, uncomplicated 2.5 milligram OD for 1 week, and complicated cases, that means ejection fraction less than 25%, and those with cardiogenic shock and severe heart failure, 2.5 milligram twice daily for 2 weeks, followed by once daily for 6 to 8 weeks. Always anticoagulation must be given in these patients. This is called a board approach: bromocriptine, oral heart failure therapies, anticoagulants, vasodilatating agents, and diuretics. Now let us see the specifics. You have a patient of heart failure. You confirm the diagnosis, assess the hemodynamic stability. If the patient is stable, now not in this case, but if the patient is stable, use hydralazine and nitrate, standard doses. You can use beta blockers, metoprolol and bisoprolol, and you can use diuretics, preferably plain furosemide. And then you determine the timing of delivery and monitor the patient very, very carefully. But if the patient is unstable, then we really need to worry. We have to optimize the oxygenation. We have to take care of the preload. We have to consider inotropes and also consider vasopressors if the patient is in cardiogenic shock. How do we approach? After managing both these cases, we go to the postpartum period. These are general principles, and we again quickly introduce ACE and ARBs or RNAs and consider bromocriptine according to the guidelines. Now, acute heart failure. Look at this. If the fetus is non-viable, go for the immediate delivery and maximally advanced acute heart failure therapy. Saving the mother is a most important step that we have. But if the fetus is viable, it's a complete collective decision. You may go for a quick delivery or you may continue with the pregnancy. It all depends on the heart team approach, gynae approach, that how do we approach this particular patient. You give both pros and cons of both these situations. Now, how do you manage heart failure in these situations? If the patient is in acute heart failure cardiogenic shock, optimize preload. Use vasodilators if the systolic blood pressure is more than 110. Consider oxygenation. Give oxygen to the patient, especially if oxygen saturation is dropping below 95 to 90%. Add inotropes and vasopressors like levosimendan. Levosimendan is available. In case it is not, in India, we can completely and liberally use dobutamine preferably, or we can use even epinephrine. Combination of dopamine and dobutamine is also helpful, but remember, dobutamine is preferred because it stimulates beta adrenergic receptors, easily available, with little effect on alpha adrenergic receptors, so that contractility is increased with peripheral and pulmonary vasodilation. So it's giving benefit to the patient. So that is why it is very important to first choose dobutamine. Then plan for the urgent delivery as soon as possible. And as I said, that bromocriptine may be considered in patients with peripartum cardiomyopathy. In case the pregnant female needs, mechanical circulatory support can be given. And after recovery, you can wean off the patients, maybe in case the patient may be referred for transplantation. But if the patient is stabilized, look at this, antepartum, heart failure therapies remain same, hydralazine nitrates, use them. Remember, these are very commonly and cheap drugs which are available, but underused drugs. Use beta blockers, metoprolol, very cheap drug, and consider diuretics like furosemide. And vaginal delivery may be considered quickly in these patients. But in postpartum periods, our aim is to reintroduce heart failure therapies like ACE inhibitors, beta blockers, RNAs, ARBs, and mineralocorticoid antagonists. These are very, very important drugs, and diuretics. Ivabradine may be considered in these patients. RNA should be avoided because of not known clearly safety concerns in the fetus, in the child. So this is a typical diagnostic and management chart of a peripartum cardiomyopathy. This is how you manage. And remember, once the patient comes out of this heart failure, these therapies have to be continued over a long time, because up to 6 to 8 months, patients has a significant chance of getting relapse or getting worsened condition. Even if the patient is having a recovered ejection fraction or recovery of the heart failure, the therapies have to be optimized very judiciously in each of these patients. A word about devices in heart failure. Remember, early implantation should always be avoided in pregnant patients. Why? Because there is high chances of improvement of LV function when the optimal heart failure drug therapy is given to these patients. But if you think patient is having repeated arrhythmias, we have wearable cardioverter defibrillators which are available. They may be used in first 3 to 6 months, especially if ejection fraction is less than 35%. Then you can use this drug. Post-heart transplantation pregnancies, these patients have a high rates of graft failure and death rate after heart transplantation. So remember, pregnancy must be avoided at least 1 year after post-transplantation and should be strongly discouraged even on follow-up. A word about hypertrophic cardiomyopathy, the third variant. Maternal mortality is 0.5%. 30% of the patients, generally it is well tolerated, but 30% of the patients experience worsening of the symptoms. It may lead to spontaneous abortion in 15% of the cases. What are the high-risk features? Arrhythmias. Remember, a patient of HCM, if you diagnose atrial fibrillation, these are the patients that are going to fare really worse in pregnancy. If they have significant diastolic dysfunction and significant severe left ventricular outflow tract obstruction. Management principles essentially remain the same. They have to be closely followed up. Beta blockers for good rate control are very important. Anticoagulation if the patient is having paroxysmal atrial arrhythmias. Cardioversion if the atrial fibrillation is poorly tolerated. And avoid hypovolemia because that will increase the gradient and these patients will really worsen, and vaginal delivery is preferred in these particular cases. So post-delivery follow-up has to be done in these patients. That is very, very important, very pertinent, because these patients, again, you have to really counsel them that how important it is to manage and to consider these patients for a proper therapy. So we have so many tools. What is my message to you? That balance is the key. Until and unless we are maintaining the balance, we won't be able to manage our patients properly. Balance of both the medical and the cardiac therapies, to use all the bullets appropriately and firing them at the right time is what is the key. Atrial fibrillation, arrhythmias, anything which is acute and acutely decompensating, cardio, relieve it immediately. But if it is a chronic process, control the rate. This is how you go. Acute heart failure, quickly control, fire the patient. It's important to save the mother, but if it is a stable heart failure, optimize the judicious drugs that are available, and closely follow up these patients over every week, or in fact, every third or fourth day. These patients are preferably hospitalized or are there in a clinical setup. Remember, any patients who have obstructive lesions like mitral stenosis or even a bailout aortic stenosis, you need to balloon these valves quickly. If the patient is especially in class 3 and 4 failure, you are going to really save both fetus as well as the mother. But these tools have to be used judiciously. I have always strongly believed that why judicious use is important is because a fool with a tool is still a fool. Thank you so much for a very patient hearing, and in case you have any questions, I would be very happy to answer them. Thank you.
Yeah. Thank you, Dr. Mohit.
Wonderful talk. I think such a complex thing which was made so simple, never felt that managing heart disease would be so simple like Dr. Mohit has explained. I think needs a really great talk. Sorry, Dr. Sharma, you were saying something?
No. Yeah. No, thank you very much, Dr. Mohit. You made a wonderful talk. And and what is actually, I think, important, like, at GB Pant in LNJP, you collaborate. Same way in AIMS, we have very excellent collaboration with the cardiologist. So what is important, I think, obstetricians and cardiologists should be very, very friendly, should take their opinion. These patients should be seen in the joint clinics, both by cardiologists as well as by obstetricians. And what is your take? Actually, recently, we had a patient. Normally, I mean, we ideally periconceptual counseling is important so that these patients plan their pregnancies, when they are in optimum cardiac outcome. So like at AIMS, we tend to see these patients, and most of them have the actually valve replacement before they venture for pregnancy. But we do have patients, of course,
that is a very pertinent point. But the problem and the challenge that we face in the Indian setup is that most of the patients, they come after getting pregnant. That's a major challenge. So you don't actually get a chance to counsel them. You see, that is what is the problem. That is why we are never in an ideal situation where the patients are coming for a counseling. In case they are coming for a counseling, we do balloon them, we do approach them, and our dear gynecologist friend do refer them to us. But sometimes they will come at 3rd month, 4th month pregnancy, and they will say like, I had underlying mitral stenosis, ab doctor sahab, hame to bacha karna hai. And then you are in a catch-22 situation. So you have to carry on. So that is why my recommendation is that often it is not possible to run a clinic, and because of the logistics and the time, but definitely a gynecologist and the cardiologist combined team approach is very, very important. Every patient who is coming with a rheumatic heart disease must be referred to a designated cardiologist for the appropriate management. And that is what my approach should be. It should be in a heart clinic, it should be even in routine OPD, sir. And we do get these patients.
Like in your first patient, if she had like mitral valvotomy at 18 to 20 weeks, this wouldn't have gone so bad. And same way, what is your take? Like the patient recently, we had a patient. So at 34 weeks, then I did a cesarean on her in the cardio OT, and they did mitral valve replace, aortic valve replace, and tricuspid repair. I mean, that was very unique. Ultimately, we could save both mother and the baby. And same way, stuck well. You know, Dr. Anjali will remember I did one in Pant, Dr. Madhuri Nigam operated, and we did.
I'll tell you, sir. It's a terrific, very, very good. But my question to you, to be very honest, is let me know if 100 such cases are occurring, how many cardiac surgeons would be happy to do this particular case?
It was just one or two isolated cases.
Yes.
Only isolated.
So that is where the problem is, sir. The problem is that, often we face in a situation which is a bailout situation. So let us be practical. A good cardiologist, having a good cardiac surgical backup, we can go to any extent, and almost out of 100 patients, we'll be able to save 80 to 90 lives. And more than 95% of the patients will be saved. But we don't get this kind of a situation. So that is why in these situations, the only option we have is just to balloon the mitral valve and often balloon the aortic valve. Tricuspid valve repair is never an option, never an option. Or even if the surgical risk is so high that, most of the surgeons would refrain from doing that. And that is the challenge that we are facing, sir. So ideal setups, everything can be done. Even the heart clinics definition is very...
I would say that, again, preventive role in
yes,
is much
perfect.
Greater. So prevention absolutely needs to be that, and that is the thing. Otherwise, we won't have these mitral stenosis with rheumatic heart disease coming with pregnancy. So we should look at that at a
totally agree with you,
level. Yeah. So,
but excellent talk, sir. Excellent talk.
Thank you so much, Dr. Mohit.
Thank you so much, sir. My pleasure.
Nice.
Thank you.
Yeah.
Can I ask a little question? Hello, Dr. Gupta.
Yeah, please go ahead, ma'am.
Yes, ma'am.
I just wanted to know about bromocriptine. I saw in your slides that there was a recommendation to start bromocriptine and carry on it for a long time for peripartum cardiomyopathy. I was just wondering, does it not affect the...
No. It was not for bromocriptine. What I'm saying was the recommendation bromocriptine has to be given for a very short time. It has serious side effects. We must understand that. My recommendations were that once a patient of peripartum cardiomyopathy recovers, the heart failure treatment management should be continued for a long time. And I'll tell you why. Because these patients, they go into remission. But remember, they still maintain the metabolic properties of a failing heart. And that is why all of us should understand that the chances of recurrence in peripartum cardiomyopathy are again very high. So heart failure recommendations are recommended for a longer time in these patients. But bromocriptine, very short time. My clear direction was bromocriptine at a defined period, but heart failure medications for a long-term period after recovery.
So that short time could be 1 to 2 weeks approximately, is it?
Ma'am, there are two conditions which I highlighted. In one condition, it was only for 1 week. And the other condition, it was only for 3 to 4 weeks. That's all. That is all. This is what is called the broad strategy, ma'am. Broad strategy.
Thank you.
Thank you. Thank you.
So thank you, chairpersons. And now we move on to the last session of the day, which is going to be a panel discussion on maternal collapse. Dr. Nalini and myself are the moderators, and I have a panel of eminent faculty in this panel. To begin with, we have Dr. Manjupuri. She is Director Professor Obs Gynae, Lady Hardinge Medical College. She is chairperson of multiple committees. She is one of the most loved teachers for many of us. She has edited several books, and her field of interest is high-risk obstetrics, quality improvement, and reproductive endocrinology. The next panelist is Dr. Kiran Guleria, a very well-known figure among obstetrician gynecologists, Director Professor and Unit Head at UCMS and GTB Hospital. She was Vice President AOGD in 2017-18, previously at Honorary Secretary of NARCHI, and she has got several special awards and recognition. And her special field of interest is in high-risk obstetrics, preterm labor, and environment. Next panelist is Dr. Sangeeta Bhasin. She is CMO, Obs and Gynae at Lok Nayak Hospital. Her special interests are in high-risk pregnancy and maternal medicine. Professor Uma Pandey, who was just on the screen, is Professor and Head of the Obs and Gynae Department at Banaras Hindu University, Varanasi. She is a fellow representative at IICC RCOG North Zone for these 2 years. And she was the principal investigator at BHU for the Champion trial. And next panelist, Dr. Jayashree Sundar. She is director at Madhukar Rainbow Hospital, New Delhi. Her areas of interest are obstetrics, both low and high risk, preventive gynecology, and adolescent health. She has been involved in running many RCOG courses, DILS, perineal repair workshops, etc. Dr. Sonia Udhavan is Director Professor from Department of Anesthesiology and Critical Care at our center in Maulana Azad Medical College, New Delhi. She is 50 publications in various journals. She is ACLS provider and instructor and is actively involved in training courses which are right now going on in our institution. She is faculty in airway workshops, PG assemblies, and in various national conferences, and she is PG examiner at various universities. Dr. Shelly Arora is our young panelist. She is consultant Ops and Gynae at CK Birla and RG Laparoscopy Hospital. She is member representative and secretary AISCC RCOG North Zone now. She is convener of MRCOG Part 3 and 2 courses in Delhi. She has authored and co-authored several chapters in various textbooks. Her interests are in laparoscopy and high-risk pregnancy. So we begin with the panel. To begin with, my first question will be addressed to Dr. Jayashree Sundar. What do we mean by maternal collapse? And is it same as cardiac arrest? This will be my first question addressed to Dr. Jayashree.
Thanks for inviting me, Dr. Deepti. So when we say maternal collapse, it means it is any acute event which could be involving the cardiovascular, respiratory, or the brain, and where there is a reduced or absent conscious level at any point in pregnancy till 6 weeks postpartum. This is what we understand by collapse, maternal collapse. So it could be an event which involves a collapse of the patient and the decreased level of consciousness or absent consciousness at any point in the pregnancy up to 6 weeks postpartum. That is the definition, and the commonest causes are vasovagal attacks usually, and epilepsy can also be a cause.
Next. So patients, Dr. Jayashree has very clearly stated what it is. And just a matter of fine distinguished, a collapsed patient may not always be unresponsive. We may have a responsive or an unresponsive patient, and we'll come to it later. And what about cardiac? Yeah.
So cardiac arrest, so the maternal collapse can be a presentation of a cardiac arrest. So all collapse is not cardiac arrest. So when we say cardiac arrest, it is a sudden cessation of organized cardiac activity, and there is a big hemodynamic collapse of the patient. And if the corrective measures are not taken rapidly, then it can progress to sudden cardiac death. But it can be reversed by CPR and or defibrillation. So that is what a cardiac arrest is.
I think that's very clearly stated. And now next question to Dr. Uma Pandey. How do we identify a pregnant or a postnatal patient who is at risk of collapse? And what are the clinical findings in a case of Dr. Uma?
Yes, I'm here.
Yeah.
Yes. So sorry, I couldn't hear the question. Was it?
Yeah. The question is, how can we identify? Is there some way so that we know that this particular woman is going to might suffer maternal collapse? So can we identify pregnant or postnatal patient at risk of collapse?
Yeah, sure. Thank you. Thanks for the question and thanks for the opportunity. There are certain features which would suggest us that now it's time to act. Otherwise, patient will collapse. So this could be in the form of how we examine the patient, what we ask the question, how responsive she is, agitated, confused, unresponsive, or if the clinical examination, the vitals like blood pressure is low, diastolic is 100, and heart rate is less than 50, respiratory rate is rising, there's tachypnea, or it is very low. Saturation, pulse oximetry saturation is showing it's somewhere close to 90,
And if she is already catheterized in the hospital, then we can always see the oliguria. All these are features are suggesting that the woman is not right at the moment, time to act, or else she will collapse.
Very well.
Also, we can also use the modified early obstetric warning scoring. It has already been explained before. Just summarize in shortcut that there is a yellow alert and there is a red alert. So single red alert or 2 yellow alert means that this is the time, please act, or else the mother would collapse or you might lose the woman.
Yes, yes. So I would like to state here, can we have the previous slide, please, Dr. Nalini? Yeah, if you would see, these are color coded. There are several early warning scores available. And this is one modified one where we also have an orange one, orange shade. And we score these parameters on various readings, and a score of 9 is more is considered a condition where we need a higher level of response. And we had validated this score in our department with Dr. Rathore. And I would like to just say, just focus on the green area. Green is safe. As you move on either side into yellow, orange, or red, we become progressively unsafe. So all these abnormal values are called as triggers. Next slide, please. Yeah.
Yes, ma'am. I'm just.
So these all are, extremely abnormal levels at either side. Either they are too low or too high. And these are the triggers. That is, we have to get alert if we find these values. But remember what I've written at the bottom. Even if these values are not so alarming, if the woman is not looking well, then you should escalate your level of care and ask for senior help. So, so just early recognition forms the first link in chain of survival. If you have early recognition of a patient at risk, you are in a much better position to save this patient. Dr. Pandey, what are the clinical findings in a case of maternal collapse?
Yes, ma'am. If we are trying to palpate the radial artery, brachial artery, whichever, and we are finding it difficult that we can palpate it, or it's very feeble even if we are able to do that. In spite of that you can palpate the central pulses, that does not indicate that the maternal condition is good. So that is very important. Then we are trying to record the blood pressure, and the blood pressure falls remarkably low. Saturation, we have already discussed. Many times when in our days when mothers were irritable in the labor room, who were not well quite, many times we did not understand in those days, but now we very well know that if mother is irritable, she is unconscious, she is agitated, she is fighting with her relatives in a woman who is eclamptic, who has had eclamptic fit. So that's not a right sign. Again, respiratory rate, or else she is gasping with all the accessory muscles and respirations that is working, or else there is a features of peripheral cyanosis that could also be there depending upon what morbid condition the mother has. If we are smart enough to do the ABG and get the values, that will also suggest us very rightly that this mother is not well. We have already discussed Q SOFA and SOFA, so I wouldn't be going into the lactate level and other things. And the last I would like to add that ideally, in ideal world, there should be coagulation profile and INR, especially if there is hepatic problem associated with that. But if you do not have, then even in peripheral hospital of Varanasi, you could still go ahead with coagulation tests, which you can observe, which would suggest. So if patient is bleeding, patient is tachypnic, she is not able to sit down. Sometimes orthopnea is also a finding of maternal collapse.
Indeed, the whole range of symptoms can be there, and in a woman who's going to face maternal collapse. But just remember, if maternal collapse is not identified and treated effectively, cardiac arrest can happen. And now next, Dr. Nalini will now tell us about a case which we handled a couple of months back. Dr. Nalini.
Yes, ma'am. Thank you, ma'am, for the opportunity. My patient is a primary gravida, 40 plus 3 weeks of gestation with a BMI of 35 kilogram per meter square. She does not have any medical illness, but she complained with a leaking pervaginum for last 24 hours and there was no labor pains. For these complaints, she came to our emergency department. The pulse was 96 per minute, BP of 118 by 76 millimeters of mercury, and general physical examination, no abnormality was detected. She was term size, cephalic free with a fetal heart rate of 140 per minute. And on PS, the clear leaking was seen, and PV was cervix 1 centimeter dilated, 50% effaced, membranes present, and pelvis adequate. The plan for labor induction was done with dinoprostol gel followed by oxytocin. And after 8 hours of effective contraction, she delivered using vacuum delivery because of fetal distress, and there is a live baby of 3 kg with EPGAR 999. Midway during episiotomy repair, she developed chest discomfort, labored breathing, and cyanosis. Oh God, is she going in maternal collapse? And please unmute yourself.
Yes, indeed. And my next question is addressed to Dr. Shelly Arora. What are the causes of maternal collapse, if we see theoretically, and what could be the possible causes in this particular patient?
Thank you. Thank you for inviting me, ma'am. So maternal collapse can result from many causes. It could be pregnancy related or non-pregnant related. For ease of remembrance, I would say we can remember it with 4 H and 4 T's and eclampsia and intracranial hemorrhage. 4 H would include hypovolemia, hypoxia, hyper or hyperkalemia, and hypothermia. So hypovolemia is most common cause, which is because of bleeding postpartum, or it could also be because of any non-obstetrics hemorrhage as well. Relative hypovolemia, as we have already listened throughout the webinar, could be because of septic or neurogenic shock or high spinal block. Hypoxia could be because of cardiac or pulmonary problem, like cardiac events, like peripartum cardiomyopathy, MI, pulmonary embolism, or amniotic fluid embolism. Hypokalemia and hypothermia is not very rare. Coming to 4 T's, like thromboembolism, which is very common these days, with pulmonary embolism and amniotic fluid embolism. Toxicity is another T, which include local anesthetic lignocaine overdose or anaphylaxis or magnesium overdose. Tension pneumothorax and tamponade are other T's, which are usually following a trauma, and the history will reveal itself. And we have already heard about the eclampsia and the preeclampsia and intracranial hemorrhage in this webinar already.
So the clue is timing of collapse, and when we decide about the possible etiologies of collapse.
Yes.
So this slide is very clear. It is in one go, you can see all possible causes which can cause maternal collapse. So can we zero in on differential diagnosis, Dr. Shelly?
With this history, we need a lot of examination before we can say. With examination, I would like to know what is her blood, what is her pulse, BP, what is her saturation, because she has cyanosed also. I also like to see how much blood she has already lost. So it can, the most common causes with this much of scenario, I can say it could be either hemorrhage, or because while we were doing an episiotomy, so has she got a lignocaine just now, and it was intravenous lignocaine instillation, or I appreciated her BMI was on a higher side, like 35. So increased BMI is a risk for embolism. So it could be either pulmonary embolism, and since it is happening just within 30 minutes of delivery, so amniotic fluid embolism usually happens either during the labor or immediate within 30 minutes of birth. So even that could be one of the differential diagnoses. And any cardiac event like peripartum cardiomyopathy or MI is also a risk factor during this time. But to pinpoint, we need a lot other investigation and examination.
Yes, thank you, Dr. Shelly. And now we are going to that very approach. I will request Dr. Sangeeta Bhasin, our panelist, to tell us what should be the approach to assessment and resuscitation when there is a maternal collapse. Dr. Sangeeta. Is Dr. Sangeeta there?
Yes, Deepti.
Yeah.
Good evening, everyone.
Now, once we come across such a patient, the first thing, of course, to do is you call for help. So you call your fellow residents, your consultants, your anesthesia team, your ICU team, your medicine person, your obstetrician consultant. So they have to be there. And then after that, we go on to the ABCD approach, basically. So now the ABCD approach is, ABCDE is basically a mnemonic, which tells us how you go about resuscitation and in which pattern, in which manner you go about it. That is, how do you prioritize things? So now the first thing you do is to assess the airway, because that is the first thing which kills first. So airway should be patent, that you have to see. This should be followed by examining the breathing pattern, the rate, the work of breathing, the saturation, the auscultation of the bilateral lung fields, because that is the second most important thing. This is followed by circulation, assessment of the heart rate, rhythm, blood pressure, the mean arterial pressure. This is followed by D and E. Now, D consists of 3 Ds: assessment of the dysfunction of the central nervous system, dextrose and drugs, and E is exposure, or rather a quick glance from quick examination of the head-to-toe examination of the patient at a glance. So this is the ABCD approach that has to be followed first.
Thank you. And now let us go through these alphabets one by one. First alphabet is A for airway. Ma'am Manju Puri, ma'am, how to check for airway? How to identify a compromised airway? In which conditions can the airway get compromised, and how to manage it? A bunch of questions for you on this.
Thank you, Deepti, and thanks for such a lovely afternoon. We've been enjoying all the sessions glued. So first is how to check the airway. I think you just have to kind of call out the name of the patient. That is what you're going to look at. And in case she responds to your call, that means the airway is okay. And in case she responds and she's coherent and she responds well, she's oriented, it would also indicate that her ventilation also is fine and she's getting adequate amount of oxygenation of the brain. So this is how we would go about assessing the airway. And then what are the signs which would mean that which would suggest that the airway might be compromised? So in case she speaks out and the voice is hoarse, there's a change in the voice, or sometimes you can hear a wheeze. If a patient is asthmatic, then there could be a wheeze. And in addition to that, it could be that the tongue might fall back. So that also could lead on to compromised airway. So basically, it is you have to hear, and that is what tells you that the airway is not up to the mark, right? And then moving on to the conditions wherein the airway can be affected. The first and the foremost which we commonly see is eclampsia, and the patient goes into post-ictal phase or she can collapse. A patient who's got eclampsia is the one wherein one would think that the airway could be affected. Sometimes when a patient collapses, she might vomit, and it could be the vomiters which could be filling up her mouth. Especially in pregnant women, it is more important because of the effect of progesterone. There's a relaxant effect. The gastric emptying time is delayed, and the esophageal sphincter, lower esophageal sphincter is relaxed. So more chances of patient having, and a distended abdomen. So, there are chances that the patient can have her, airway blocked with the help of, because of the vomiters or some secretions. And especially in preeclampsia and eclampsia, there is laryngeal edema also. So all these things mix up and they can kind of, cause airway obstruction. So then one should never miss out. It could be a loose tooth or it could be anything, although our patients are young, but nowadays we have older patients as well becoming pregnant, and there could be others with a poor oral hygiene. And I would also keep, some corrosive intake. There could be some suicide attempt or something. I would keep that also in mind because, we have to think bigger so that we can clinch on all the diagnosis. So I think that's all what would come to my mind. And then one more question. Sorry?
How to manage a compromised airway?
Yeah. So here I would immediately, I would be at the head end. So I'll immediately lift up her chin or do a jaw thrust. And then immediately with the help of suction, I would, clear up the airway. And then put in a oropharyngeal or a nasopharyngeal, airway to kind of protect the tongue from falling back. So that would be my approach. And in a pregnant woman, one would want to intubate her faster in case she's unconscious. Because of that, progesterone effect, I would want to prevent, further aspiration and other things. So intubation should be done as fast as possible. But keeping in mind that intubation may not be as easy in a pregnant woman as it would be in a non-pregnant woman. So I would definitely secure her airway with the help of a oropharyngeal or a nasopharyngeal,
Thank you, ma'am. Now, Dr. Nalli will show us very short video clips on how to insert airway devices.
As rightly said by Manjupuri ma'am, we have to insert OPA and NPA, and intubation is to be done by experts only. So for OPA, we have to measure the exact size, which is from angle of the mouth to the angle of the mandible, and the nasopharyngeal airway from tip of the nose to the tragus or earlobe, and diameter should be approximately same as the little finger of the patient. Now I show you the video. Before using these OPA and NPA, you should use a lubricant jelly, water-soluble lubricant jelly like lignocaine. And for inserting OPA, begin inserting the airway into the mouth with the tip pointed towards the roof of the mouth. That is concavity up, and then rotate 180 degree. Concavity up and then rotate 180 degree in an advance, and then fully insert it till the flange of the OPA should faces the patient's lip. And for NPA, after lubricating, we'll insert the nasopharyngeal airway posteriorly parallel to the hard palate, not cephalad. And with a rotating movement, we should put it and bevel should face the nasal septum. So this is a very simple technique, and at least they can able to open the airways, and then we can secure the airway. Moving ahead. Thank you, ma'am.
Thank you. Dr. Nalli, could you tell us what were the findings in our case for that A for airway?
Yes, ma'am. As rightly said, ma'am, I have asked the name of the patient, and patient could able to speak. So my patient, the airway is patent.
So after A, we go on to B. B is for breathing. And my question is for Dr. Kiran Guleria. Ma'am, how to check for breathing in a collapsed patient, and what to do if breathing is absent but pulse is present?
Yeah, thank you, Deepti. And first of all, thank you for inviting me. So you know that in a collapsed patient, she may not respond to your call. So in that case, I think we have to look for certain signs and for whether she's breathing or not. And many times, you must have seen our anesthetists, if they feel that there is no breathing, then they would quickly bare her chest and look for chest wall movements. You can even feel for the chest wall movements. Otherwise, you can, also kind of feel for the breath. You can put your hand or finger in front of the nostril and see whether she is breathing or not. And rest. Otherwise, you can look for the, you can auscultate directly either the trachea or the lungs for whether she's breathing or not. So otherwise, I mean, if you do an ABG, you can do an in-depth assessment. But for quick assessment of air breathing in a collapsed patient, you should not spend more than 10 seconds, because then you have to start taking the action, because oxygenation, maintaining the oxygenation in a pregnant woman is very, very important. So you should spend as less time in assessing and then quickly go on to some interventions to improve her oxygenation, because pregnant women, they become hypoxic and anoxic very, very fast. So any intervention should be started very early. So as you said, in a patient where the breathing is absent, actually, I think you have written if the breathing is present. Actually, where the breathing is absent and pulse is present. Yeah. So in that case, you should quickly go on to maintain her oxygenation by giving her a non-lead breathing mask and giving her oxygen, 100% oxygen at the rate of 15 liters per minute. This is to increase, increase the fraction of oxygen in the inhaled air, and hence to maintain, as we heard in one of the lectures, that if you do it with a non-lead breathing mask, the fraction of inhaled oxygen is very, very high, and almost like it is almost 90% comparable to your intubation. So that is something which you can easily do. So you start doing that, and then you see for the signs of improvement of oxygenation, whether the SpO2 increases, whether her respiration settles down, and if she has cyanosis, whether she disappears. And then you have to, if you are unable to achieve these targets, in the meantime, you have your resuscitative team coming and somebody who is, expert at intubating the patients who are pregnant, who understands the difficulty of, intubating a difficult airways. That person, then if you are not able to maintain those targets, that means SpO2, or we are not able to ventilate her, or she is going also into circulatory collapse, or her neurological status is kind of deteriorating, then it is the time to intubate her and put her on a ventilator.
Thank you, ma'am. And we have two very short video clips on how to use ambu bag and how to use supraglottic airway device.
Yes, ma'am. Ma'am, before intubation, our obstetrician colleagues should know exactly how to resuscitate the breathing part. For that, there is an ambu can be used using 100% oxygen or a supraglottic devices. So this is a video of the ambu. At least everybody should know how to apply an ambu.
The bag mask assembly. This is the self-resuscitator or the ambu bag. And this is the face mask. They are attached like this, and the assembly is complete. Mask ventilator patient, the mask is kept on the patient's face such that the apex of the mask sits on the bridge of the nose and the base of the mask sits between the area of the lower lip and the chin, or commonly known as the submentum area. The seal is made with the other hand using the index finger and the thumb in the shape of the alphabet C. The C compresses the mask from above, and the remaining three fingers, which resemble the alphabet E, are then aligned over the bony part of the mandible, and the maneuver of gentle head tilt and chin lift is completed, and the patient is ventilated such that 1001, 1002, 1003, 1004, 1001, 1002, 1003 to make the back mask.
And this is a video of supraglottic airway device.
This is a second generation supraglottic airway device, commonly called as IGEL. It's a preformed supraglottic airway device. It is second generation because it has two openings, one for the airway and one for the gastric empty or gastric drainage. This is the definite, a part of the definite airway in ACLS. It is used as a conduit. Before insertion, the size selection is done based on the parameters which are also written on the specific device. In this case, this is size 3, which could be inserted between the patients who weigh between 30 to 60 kilograms of weight. Before insertion, the device is adequately lubricated. Patient is positioned with head tilt, chin lift, the heel of the hand resting on the forehead, and using fingers and thumb, the oral cavity is opened up. The device is inserted such that it has to run close and along the hard palate and not along the base of the oral cavity. During insertion, it has to go smoothly in one go. After insertion, on the universal adapter, 15mm adapter, breathing circuit or ambu bag can be attached, and the patient will be ventilated as 1001, 1002, 1003, 1004.
I want to just add, ma'am, this LMA is being designed for use by paramedics in out-of-hospital resuscitation. This is a very simple device which can be inserted within 10 to 15 seconds, and our fellow obstetrician can use it when they are waiting for the anesthetist to come.
And Nalini, I have seen even in hospital setting, even the anesthetist using this. Sometimes the intubation is difficult, so in between, if they are not able to intubate,
yes, ma'am, it is a rescue device. That is why it is called rescue, and this is a wonderful device which can take care of the airway of the patient. Moving ahead.
Okay, now finding in the given case. Yes, what are the findings in the given case? Dr. Nalini will tell us.
Yes, ma'am. When we have examined the breathing assessment, my patient was cyanosed with tachypnea of respiratory rate 38 per minute, and she is hypoxic with 51% on room air, and chest auscultation is air entry reduced with conducting sounds. And for this resuscitation, I have started her on 15 liters of oxygen oxygenation per minute by non-free-breathing mask, and ABG sample was sent.
So after B, it is C. And my question is for Dr. Uma Pandey. How to assess the circulation in a collapsed patient? How to resuscitate a hemorrhaging patient?
Yes, madam. Thank you for that question. Very quickly, I would describe the assessment of circulation in this woman who has collapsed. As you walk in, you look at the hands of digits of the patient. They are pale, pink, blue. This woman is blue, apparently. I could guess at peripheral cyanosis she has. Then also, while you are looking at that, you will touch the woman. Is she hypothermic? Is she very cold, or is she not very cold? Then the one important thing which we do is capillary refill time. Okay, and that's a very good test, very fast. Apply cutaneous pressure for 5 seconds on the fingertip and hold it like this, please, with enough pressure that will result in blanching. And this blanching should be reversed back within 2 seconds. If it doesn't happen, that means that the output from the heart isn't good enough to result in good capillary refill for that particular woman. We have discussed time and time again about pulse rate. In a woman who has collapsed, there's no point checking radial and brachial. It is good to go ahead with the central pulses, or best would be to hear the heart rate, auscultate that and count that. Take into account the heart rate. That is always better. Then obviously you palpate the central pulses as well, like you will do for carotid and other pulses. Blood pressure, I didn't mention in the beginning, but obviously blood pressure is very, very important. All of us know that. Auscultation for the heart rate, auscultation for the chest, for the Krebs, for the wheezes, for the cardiac problems. And if patient is already on catheter, then obviously we will have a look of how much urine she has passed since she has been with us, and take it from there. So that is kind of a very, very quick examination for a woman who has collapsed. Majority of the times we are in rush because we want to resuscitate, and therefore we go for heart rate directly. But yes, if you are good enough and if there is palpable radial and brachial, then you would be able to do that. Right. And then I was also asked, how would you resuscitate the hemorrhagic woman? I think we have been resuscitating since this webinar started, and I'll just briefly revise this. So first and foremost, help. So it depends which city you are. If you're in metro, if you're in Mumbai, if you're in Delhi, then you will have better help buzzer facility. We have either a bell or somebody shouts, "This woman has collapsed, please come," something like that. So that is help. Second is you have to ensure that you are safe. She is not being electrocuted or something like that. That's very important. We have already discussed ABC. We have already discussed how much oxygen we would give to the woman. With the NRBM, non-reservoir bag mask, we have discussed that. Okay, and we have to aim to maintain the saturation of more than 94%. There are centers who are also encouraging obstetricians to do intubation. So far, I've not been trained neither anywhere, not in BHU or anywhere. So I don't do that. Okay, we have already discussed 2 wide bore cannula, 14, 16. Okay, if you cannot do 14, do not just mess around with 14. Please do something, give 16, increase blood pressure, do 18 if you cannot do even 16. But ऐसा नहीं कि मैडम 14 नहीं कर पा रहा है तो क्या करें, बैठना नहीं है, करना है, कुछ काम करना है. Then obviously a woman has collapsed, and so we'll take the history and the examination. We'll take the history from the family members if they are around, and also obviously examination we would do for the patient, and we will think about in our mind, think aloud what could have caused this. Like the woman who was 40 weeks and she had BMI 35. She came with leaking for 24 hours, but her membranes were intact, and suddenly she collapsed. Majority of the time people will jump amniotic fluid embolism, but is it so common? No, it's not actually. So we have to be very cautious before we can jump in. We all know how to arrange blood, cross match, the foot and elevation, keeping patient warm, because hypothermia could be a biggest killer in couple of setups, may not be in our country. Obviously, we have to check for urinary output to ensure that the kidneys are working well. If she's bleeding, I gather this my lady is postpartum, and therefore vitals and other monitoring. And if she's bleeding, if she's postpartum hemorrhage, I'll manage according to postpartum hemorrhage, which we know. I'm not going into that. It says like mota moti, we know that
these are the findings. These were the findings that we got in these cases. In our case that we were talking about, when we assessed for C, these were the findings.
So heart rate was 130 per minute, but was regular. Peripheral pulse is feeble. Capillary was increased. Blood pressure is down. Foley is inserted. 100 cc urine drain, but we do not know when was the Foley is inserted, so that wouldn't give us much idea. And sinus tachycardia she has because she has been losing and she's hypovolemic and no active bleeding. So her and saturation breathing.
Saturation was 50% on room air, ma'am, and we had applied
that we are told in B.
We have done in the B part.
Okay, so actually we are trying to walk the audience through, all our delegates through our ABCDE protocol to make them understand what it is about. So I have broken the whole assessment into ABCDE, the way it is recommended to be done. So after C, we move on to D and E. I will request Dr. Sangeeta to tell us in a little more detail about D and E, because ABC we understand easily. D and E, we need to understand how to assess for D and E.
Thank you, ma'am. Thank you.
Now D stands for three things. So D stands for disability, for dextrose, and for drugs. And E stands for exposure, as I've already said before. Now disability means disability or dysfunction of the central nervous system. And this can be assessed by three things. The first is assessing the size and symmetry of the pupil, as well as the reaction to light. Then we need to assess the presence of any focal neurological deficit. And number three, and the most important, is the assessment of the consciousness level and the responsiveness of the patient. And this is the AVPU assessment. So this is done by measuring the alertness of the patient. That is, she's alert to the environment. Her response to voice or verbal responsiveness, whenever you call out to her, she responds, and responds to painful stimulus. And the fourth is unresponsive, that the patient is totally unresponsive, does not respond to anything. The second D is dextrose, and we all know that hypoglycemia or reduced glucose levels are an important cause of collapse in some patients. So blood sugar level has to be assessed. The third is drugs. Now, this is a very good opportunity to find out the drugs the patient is on, so that we know that maybe there is a reaction to certain drugs which have been given, or a reaction between two drugs that she is taking. So suppose the patient is has been given excessive magnesium sulfate, or she has reacted to it, or she has received post-operative morphine, or maybe she is on insulin or or oral hypoglycemic agents. So we need to know the drugs that she has been given and whether there is any reaction to these drugs. Now, this is about D. E is exposure. And within the limits of decency and privacy and dignity, of course, you expose the patient and do a quick survey, first from a bird's eye view, and then a head-to-toe quick examination to find out any cause that could tell us about why this collapse has occurred. So like, for example, the presence of any open wounds or presence of any abdominal distension, presence of swelling in the legs for DVT, and of course, the uterus tone and the contour should be assessed. So this is D and E.
Thank you, Dr. Sangeeta. Now, Dr. Nalini will tell us the findings and summarize the case findings in toto.
Yes, ma'am. My patient in D part is very anxious and restlessness, and she's having no visible active bleeding. The uterus is well contracted, its contour was maintained, abdomen was soft, and there is no calf tenderness. So in totality, summarizing my patient is an immediate postpartum paravel live one, delivered 30 minutes back, and during episiotomy repair, she developed chest discomfort, labored breathing, and cyanosis. Her airway is patent. In breathing part, she is having tachypnea, cyanosis, and hypoxia, and her air entry was reduced, and hypoxia is up to the level of 51%. And we had started the 15 liters of oxygenation by NRBM. Circulatory status, she is tachycardic with peripheral pulses, very feeble, and capillary refill time of 5 seconds, which is increased, and the systolic blood pressure of 80. And in Foley's insertion, 100 cc of urine was obtained. And while delivery, her bladder was evacuated. But on monitors, it is sinus tachycardia. The features are going a little not in favor of hemorrhagic shock. Indeed, the patient is having very anxious and there is no evidence of any external or internal hemorrhage. Although we have resuscitation, we have done the resuscitation parallelly, but this is our patient.
Okay, now Dr. Sangeeta, what to do after this ABCD assessment?
So once we have completed the ABCD protocol, we now go on to, we have to basically find out whether the resuscitative measures that we have instituted, have they been effective at all or not? So the patient, if the patient is stable, so you can continue with these measures. If she has deteriorated or she is not improving at all, you might need to step her up into either the ICU or she may need to be taken into the operation theater. So you basically have to reassess, and a rapid and a quick and repeated assessment, clinical assessments are very important because these patients, the condition may keep changing from minute to minute. So what is important is this, that you repeatedly keep on assessing and reassessing to find out what is wrong. And otherwise you have to reassess your ABCDE and find out what is wrong. Yes, and once the patient is stable, then it is only after this that you go on to your secondary assessment.
Okay. So this is what we will probably like to see in history. And Dr. Nalini is now going to tell us the reassessment finding of the patient.
Yes, ma'am. As rightly said by Dr. Sangeeta, ma'am, we have done the resuscitation and now we have to see the response of the patient. My patient's breathing, the saturation has improved to 90 and tachypnea settles up to 30. She's showing the signs of improvement, but not still completely stable. She's still having the tachycardia of 116 per minute and systolic BP still remain 80 systolic. There is some problem out here. But we don't see any evidences of external or internal hemorrhage.
So we move on to do focus history.
With this, since my patient is showing signs of improvement, I just take a very quick focus history and do a very focused examination. In focus history, I found there is no allergy. She was received oxytocin in the usual doses and 5 ml of lignocaine was infiltrated at the epi site. No past illness. Last meal time, she was on liquids for last 8 hours and taken last 2 hours back. On focus examination, uterus was well contracted and there is no evidence of any vaginal hematoma, cervical tear, broad ligament hematoma, and there is no calf tetanus. So this is my patient. And the investigations which we have cited earlier was suggestive of, ABG was suggestive of respiratory alkalosis with hypoxia and the hemoglobin of 10.3 grams, lactate of 1.1 millimole per liter, sugars of 108 milligram, and ECG shows sinus tachycardia on monitors and urine albumin sugar ketones was nil.
Yes, now that we have all the basic investigations and examination and everything, now what is the likely cause of collapse in this case? My question is to Dr. Shelly Arora.
Yes, ma'am. It looks like she had through a pulmonary embolism or amniotic fluid embolism.
Yes.
Since we have ruled out the hemorrhage part, there is no external or internal bleeding. ECG was normal with some sinus tachycardia, and there is no signs of anaphylaxis, and lignocaine was instilled 5 ml. And so it is more likely to be pulmonary embolism and amniotic fluid embolism.
So how to diagnose pulmonary embolism and amniotic embolism? What are the clinical features and investigations? My question is to Dr. Manju Puri.
Yeah. So basically, the problem here seems to be related to lungs because the patient is cyanotic and she's had, respiratory, she had difficulty in breathing and coupled with collapse. So thromboembolism is the, first line. And because, we need to look at the risk factors in the woman. So one is that she is obese, that was one. And we don't know her age. You have not mentioned the age. So we have elderly people these days. Then, pre-eclampsia, twins, IVF pregnancies. We have the, this combination these days. And we kind of forget giving or, doing a risk assessment in the antenatal period. And we miss out on doing antenatal anticoagulation in these patients. So all those factors have to be assessed. So this could very well fit into a pulmonary embolism. As far as amniotic fluid embolism is concerned, so whenever I have a patient who has this kind of respiratory issues, so I would, ABG you already told, I would want an X-ray chest also done, because X-ray chest would give us the cardiac size and then would guide me whether I need an echocardiography or not. And at the same time, I would definitely want a coagulogram in this patient, because in case the patient has a coagulopathy coupled, then it would be easy for me to make a diagnosis of amniotic fluid embolism. So that would be a factor which will go in favor of amniotic fluid embolism. So my preparedness will be different and my management also would be different. And in addition to this, I think we need to rule out DVT by doing ask for a ultrasound of the leg veins, and also for sometimes iliofemoral deep vein thrombosis can also happen. So it has to be a combination of that I would want. And D dimers do not have so much of value as far as this is concerned. So if the heart size is bigger, then maybe I might get a pro-BNP as a point of care test, but not in this patient. I'm to say, apparently my first line would be to get an X-ray chest done and a coagulogram done to differentiate between pulmonary embolism and amniotic fluid embolism.
Dr. Nalini, can you move on to the next year?
And I would also like to rule out inversion uterus. That was not pointed out. So I think the contour, contraction, contracted uterus and inversion, the contour of the uterus also should be looked up. Although with cyanosis, I would think more of a lung kind of a thromboembolic phenomenon. Yeah. Thank you.
Yes. So now the case continues. Dr. Nalini will tell us what happened to this case.
Yes, ma'am, as rightly said by Manjupuri ma'am, that we have a differential of amniotic fluid embolism, or it could be a pulmonary thromboembolism. Keeping this obstructive shock in mind, we have taken a consultation with the critical care team, and we have planned for intubation, ventilatory and inotropic support and giving anticoagulation. However, she threw a seizure with frothing from the mouth. She was immediately managed by left lateral position. Suctioning was done and a Goodell's airway was placed to maintain the airway, and 100% oxygenation using NRBM was attached. But immediately after seizure, the patient became unresponsive. Oh, call for help. In this case, I'll activate a code blue team because my patient is unresponsive, which includes obstetrician, intensivist, anesthetist, and a pediatrician. And I've quickly checked the breathing and the circulation in at least 5 seconds, but not more than 10 seconds. In my patient, there is no breathing, no circulation. Carotid is absent. Is it cardiac arrest?
So here we come to the most difficult aspect, and we have Dr. Sonia Vadhavan helping us to deal with this patient. And Dr. Sonia, can you tell us how to identify and manage a cardiac arrest? And also what are the modifications in routine resuscitation when we are dealing with a pregnant patient, and the common medications we use while managing a maternal cardiac arrest? Dr. Sonia.
Thank you, Dr. Deepti, Dr. Nalini, and Dr. Smita ma'am for giving me this opportunity. Well, the patient, as has already been initiated by Dr. Nalini, she has said how to identify if we feel that the patient was responsive and suddenly becomes unresponsive. What we need to do is assess responsiveness. For that, we take a few seconds. Facing the victim, we have to firmly tap on the shoulder and call out loudly. So when we do that, if we don't get any response, then we immediately activate the code blue team. The code blue team in this has already been specified, consists of the obstetrician and the anesthesiologist, intensivist, and the pediatrician. And immediately also ask this person who is the first responder becomes the team leader. And after donning the personal protection like gloves and face mask and gown, does the activation of the sees for the responsiveness. No response, activates the emergency medical services, in this case the code blue team, through the other team member, and also ask that person to get the defibrillator and monitor and attach the monitor and tell the rhythm, and then goes back to the patient and looks, listens and feel for the presence and absence of breathing and circulation. So circulation, here we are looking at the carotid pulse. Because the patient was unresponsive, we have gone on to the BLS algorithm where circulation comes before airway and breathing. So we feel for the carotid pulse, and how we do that is that we count 1001, 1002, 1003, 1004, 1005 up to 10 seconds. And it has been seen that by teaching and training our residents and following this 1001, 1002, we are actually spending 1 second in doing so. And at the same time, our eyes are looking at the chest and abdomen for a visible chest pulse. So if either pulse and breathing both are absent and patient was unresponsive, now the team leader will ask the next provider to take care of circulation. Circulation is the most important part. Chest compression, good quality chest compression is the most important part in getting a return of spontaneous circulation. For ROSC to come back, good chest compression, which consists of giving compressions at the rate of 100 to 120. But in obstetrics, it has been suggested that maintaining a rate of 100 per minute. And the depth of compression is about 2 to 2.4 inches, which is about 5 to 6 centimeters depth. And you have to allow a complete chest recoil and minimize the interruptions between two sets of compressions to less than 10 seconds. At the same time, till this time, if we had not exposed the chest, we had to now expose the chest to see the site of compression. So site of compression corresponds to the lower half of the sternum. And for this, we see the intermammary line. Just below that, we place the heel of one hand and interlock it with the other hand with our elbows locked and the shoulders vertically on top. This is the position. And the person who is giving the chest compression should have the hips higher than the chest of the victim. Only then can we give good quality chest compression. Now, the main issue in an obstetric patient is that there is an element of iotocaval compression. May not be true in this patient because she's a postpartum patient, but in other patients where the period of gestation is more than 20 weeks of gestation, then a continuous left uterine displacement has to be maintained. Initially, they used to suggest that you can do a tilt, but by doing a tilt, the quality of chest compression suffered, and even the ease of applying paddles for defibrillation or for managing the airway or for, so it has been suggested after in the last algorithm of AHA in 2020 that you should ensure the uterine displacement, which can be manually done with two hands onto your side if you're on the left side, or away from your side if you're on the right side. And this has to be continuously maintained. So you need another provider for that. Now, after we have taken care of circulation, we come to airway and breathing. And it has been well mentioned by the prior panelists also that we need to open the airway. And like Madam has already said, we should be sure, because this patient was a post-ictal patient, there might have been vomitus, regurgitation of gastric content. So we need to do a good suctioning, and we need to do a head tilt chin lift. That is a maneuver which we do to take the tongue which has collapsed back against the posterior pharyngeal wall. We have to get it forward, which is the most common cause of airway obstruction in these unresponsive patients. And we do a head tilt chin lift to open the airway. And now we need to administer 100% oxygen because the patient is in cardiorespiratory arrest. So we can initiate it with a bag mask ventilation, as has been shown initially with a nice video. When we do 30 compressions with the person who's taking care of circulation and 2 breaths, and each breath is delivered over 1 second. So 1001 for the first inspiration, 1002 for passive expiration, 1003 for the next breath, and 1004. This is till such time that we have not secured the airway. So if the first breath is ineffective, that means if we do not see a visible chest rise, then we should reposition our mask and again improve our head tilt chin lift, and then try to deliver the second breath. At the same time, we have connected oxygen to the ambu bag and face mask. And if we connect a reservoir back to the ambu bag, we can give up to 90 to 100% oxygen, which is a must at this time. And as has been emphasized, since we are dealing with a difficult airway, we are dealing with a postpartum patient who has a high level of progesterone, they are more prone to aspirations. So we would like to secure an airway at this point. If the team, the most trained person in the team can take care of airway and breathing, because insertion of a supraglottic device it also requires some amount of skill. So if you are used to doing putting in a supraglottic device, you can do that. And if you have to intubate, then a person who's regularly performing intubation should only do it, because as Dr. Deepti and other panelists have already mentioned, it's a difficult airway. And once the airway, the advanced airway is in place, then we do not do 30:2. Then we independently do ventilation and independently do chest compression. Ventilation is then done at the rate of 10 per minute. That means 1 every 6 seconds. And chest compressions can go on uninterrupted at 100 per minute. Now, the person who was taking care of the monitor has come back and has attached the monitor and has said that the rhythm is a pulseless VTAC or a VFib. These are shockable rhythms, the non-shockable being PA and asystole. So if it's a shockable rhythm, and most of our defibrillators are now biphasic, so we are giving 120 to 200. If it's a monophasic, we give the maximum, which is 360 joules. And we do not wait for seeing what kind of rhythm has now. If suppose there is a change of rhythm or it has not, we immediately resume chest compression, and we do that for 2 minutes. Between the person taking care of circulation and ventilation, they keep on switching roles every 2 minutes, because the person who was giving chest compression, that is the most difficult task and gets tired. So every 2 minutes, you have to interchange between the two resuscitators. And for 2 minutes, it's roughly corresponds to about 5 cycles of 30 compressions to 2 breaths. 30 compressions are normally delivered in less than 18 seconds, followed by 2 breaths, which take another 3 to 4 minutes. 3 to 4 seconds. So this was, and then we have the IV line, which is put in by the fourth or the fifth member of the team. And the IV line should preferably be put above the level of the diaphragm. And we do relevant samples, like if in case it was a case of APH, we would have sent for blood grouping, cross-matching. And otherwise, if there is any history of magnesium sulfate, then we can give send for serum magnesium levels. ABG, of course, needs to be done. And IV, normally the fluid that we start is normal saline, or the second fluid of choice is ringalactate. Then if we come on to the algorithm, I think you have the algorithm chart also. Yeah, if we come on to this algorithm, you have either the VF and the pulseless VTAC, which are the shockable rhythms, and the asystole and PA. Before I come on to this, the sixth member, who is a very important member of this team, is the record keeper. So they record from the beginning what is the rhythm at the time of cardiorespiratory arrest. What was it, a VF? Was it an asystole? What was the intervention given? When were the drugs given? When was the shock given? Did the rhythm change? How was the quality of the chest compression, ventilation? Because all this can be at the end of the whole resuscitation. You can have a summarizing and reevaluation of the kind of resuscitation sequence that you have done. Dr. Nalini, coming back to your VFVT and asystole algorithm, if I can see that, yeah. So if we see that once the monitor is attached and it's a VF or a pulseless VTAC, then we have to immediately give 120 to 200 joules of a biphasic, and followed by 2 minutes of CPR. And during this time, the person who was taking care of IV will secure the IV, connect the fluid, send the relevant samples, and keep epinephrine loaded. Now at the end of 2 minutes, again, the monitor will be seen for the nature of the rhythm. If it is again shockable, that means the same rhythm is persistent, then we will deliver the shock. And after the second shock, we immediately give epinephrine, which comes in 1 ml ampules, and it normally is written 1 in 1000, which is actually 1 milligram. So what we do is that we take 1 ml of that, we dilute it in 9 ml of saline. And since we are using a peripheral line, we push the fluid, we push the epinephrine, and then we put another 20 ml of bolus saline to push the drug into the central circulation. And at this time, we should even consider an advanced airway. The advanced airway I've already mentioned. Dr. Nalini has shown a very good video of the iGel, which is a second generation supraglottic device. So it has a separate drainage tube for the gastric channel. So you can do a gastric deflation also. And then if it was the PA or asystole, then we don't have to give shock. We just give epinephrine as soon as possible, continue with chest compression. Now, the second question which Dr. Deepti mentioned was what is special about a pregnant patient? Well, the rest of the things remain the same. However, we continue with the good quality CPR. We go on to the ACLS interventions. But assembling the maternal cardiac arrest team is very important, and considering the causes of arrest. It can be A, it can be some anesthetic drug complication, B, it can be bleeding, C, it can be any cardiovascular underlying disease, D can be drugs, E can be an embolism, F can be some febrile cause, and or there can be other non-pregnant causes like maybe 5 H's and 5 T's, or even preeclampsia, any of these. So we have to keep on trying to treat the reversible causes. The main two considerations are performing either the maternal interventions, which is for the mother, and or performing the obstetric intervention, which is for the obstetric part. So maternal, we again maintain the airway, administer 100%, give IV, all that has already been mentioned. If IV magnesium was being given, to stop and give its antidote, which is a functional antagonist, is the calcium gluconate. That is given 10 ml of 10% calcium gluconate is given. And if we come on to the obstetric intervention, then maintaining the continuous uterine displacement, we detach fetal monitors because that can interfere with the resuscitation. And we have to, at the same time, prepare for perimortem cesarean delivery. If there is no return of spontaneous circulation in 5 minutes, we go ahead with the perimortem cesarean delivery. That I think, Dr. Deepti, your team will be able to.
Yes, we will be covering that.
Yeah, so the only thing, the commonly used drugs, as I've already mentioned, epinephrine, it comes in 1 ml ampules, and 1 milligram in 1 ml. It is given intravenously, intraosseously only if IV access is not there. And you need special needles for intraosseous. So it is given every 3 to 5 minutes because the half-life of epinephrine is only 3 to 5 minutes. So it is given with every alternate cycle. I mean, every alternate 2-minute cycle. That means every 4 minutes it's given. If and this is, I've already mentioned how it is to be given. 1 in 1, it is diluted in 10 ml of saline and then followed by 20 ml of saline flush. The other drug which we can give is amiodarone, which is, suppose we have given first shock, then the next shock we give epinephrine. Even then after 2 minutes we see still it is VFVT. Then we can give amiodarone. It is given in the dose of 300 mg. One ampule has normally 150 milligram per ml. So we give 300 mg and the second dose can be another 150 mg. Instead of amiodarone, we can, if we don't have that, we can even give lignocaine in the dosage of 1.5 milligram per kg body weight. The other drug, calcium, is typically a functional antagonist for magnesium sulfate if we are thinking in terms of severe preeclampsia and patient or eclampsia and patient has showing signs of magnesium toxicity like somnolence or visual, and in this case, it could be a respiratory arrest or a cardiac manifestation of high magnesium levels. Not in this particular patient, this is a non-PIH patient. So these are the signs of magnesium toxicity and calcium can be given. Sodium bicarbonate, we don't normally recommend. It has been moved out of the AHA guidelines unless there are specific indications that there is a documented hyperkalemia or the pH is very low, less than 7.1. Then we do give because these drugs otherwise don't have an effect. There is a rare possibility of local anesthetic toxicity, which is more seen with epidural rather than spinal because the volume which we give in epidural is much more. And the epidural vessels are quite engorged because of the aortocaval compression. So there is more absorption. So in this, if we are suspecting local anesthetic toxicity, we give epinephrine, which is again adrenaline in the dosage of less than 1 mics per kg. That means roughly about 50 mics. And if we have diluted 1 milligram and 10 ml, that means 1 ml of that will have 100 mics. So roughly half a ml of that. And we should always have 20% lipid emulsion in our OT ready, that in case there is ever any local anesthetic toxicity, we should be able to treat it by giving lipid emulsion, which is in the dose of 1.5 ml per kg. We can repeat the dose, we can maintain an infusion, but we don't go beyond 12 ml per kg. And these are the most commonly used drugs for resuscitation for cardiac arrest in a pregnant patient.
Thank you, Dr. Sonia, for such a nice and detailed explanation. Now we did CPR for our patient, and Dr. Nalini will tell us what was the outcome.
Yes, ma'am. After extensive training given by Dr. Sonia, we have started the high quality CPR, and 200 joule of shock was given and 1 milligram of epinephrine was given. And we are successful in achieving the reversal of spontaneous circulation after 2 cycles of CPR.
So the next question is what to do next. So how to carry out post-return of spontaneous circulation management? Dr. Jayashree Sundar.
So luckily our patient has been resuscitated. So once the resuscitation occurs, we should again use the ABCD approach and keep a watch on her and decide on where she should be shifted. But some things that we should keep in consideration when we are handling this patient is, obviously we have to do a controlled oxygenation. Airway lung management should be done, and the oxygen saturation should be maintained between 94-96%. We should prevent hyperoxia in these patients. BP control should be kept adequately. We should look for the precipitating cause for this damage that has occurred, and ECG should be done for the patient. Temperature control is very important, and we have to continue thrombolysis as was said. And therapeutic hypothermia can be maintained because she has had a cardiac arrest, and we don't know the extent of the brain damage that has happened when she was being resuscitated. So obviously the oxygen saturation, as I said, 95% with so these are the things that we need. We don't need to go to the nitty-gritties because all the airway management and all will be taken by the anesthetist. But for a gynecologist, obviously the most important thing is we should understand the precipitating cause, and we should be able to shift the patient accordingly, and we should prevent any hyperoxia trauma to the patient, and we should maintain some amount of hypothermia to prevent any brain damage. So these are things that we should be remembering for the patient as we do the post-resuscitative care.
Thank you, Dr. Jayashree. And now my question is to Dr. Kiran Guleria. What is resuscitative hysterectomy or perimortem cesarean delivery, which Dr. Sonia just mentioned about? What is the 5-minute rule for this procedure? And how do we go about logistics and technical aspects of this procedure?
Yeah, thank you. And in the beginning, I think I will tell you that I personally don't have any experience of perimortem. I never got an opportunity also, you can say, because by the time this concept came, my residency was over. And I think these are the residents who are resuscitating the patient there, they should be trained in this procedure. So, this perimortem cesarean section was initially started with a focus on the intact survival in patients or in mothers who were dying. So that is how the concept came, and then they realized that if the fetus was delivered within the 5 minutes, it was found to have an intact survival because of, and then with this background, they realized that pregnant women tend to become hypoxic and anoxic much earlier because of the physiological changes which are there. And so they become more prone to hypoxic damage or anoxia if usually within 4 to 6 minutes of the cardiac arrest. So then came the term, the resuscitative hysterectomy, which is actually, coined by the other non-obstetric, the people who work in the intensive care units. So this was primarily to assist in improving the maternal outcome rather than focusing on the infant survival. So it was found that women who have uterine size more than 20 weeks, and if they do not respond to your effective and very high level of cardio CPR, then doing a quick hysterectomy, which should usually be done within the 5 minutes of the cardiac arrest, it improves the maternal survival. And how does it do this? How does it improve the survival? There are certain factors. It was found that it would, relieve the aortocable compression, so it will increase your venous return and cardiac output by almost 60%. It would also decrease the oxygen consumption by the patient because the fetus is out, placenta is out. Then it will facilitate your chest compression, and also ventilation can be made easy. So there were a lot of advantages of doing this. And also to the extent that you can go through the same incision and you can even do the internal chest compression by placing your hand on the posterior aspect of the uterus and compressing it against the chest wall. So, but however, it is found that there is no benefit of this if the uterine size is less than 20 weeks. So that we must have to understand. Now, as far as the logistics and other technicalities are concerned, so 2 or 3 things which I want to make sure, make clear is one, that you have to carry out this procedure at the site where the maternal resuscitation is going on. That means even in any ward. So all wards which have a emergency tray should also have a very, you just need a one equipment that is a fixed blade scalpel, which should be there in all wards which house the antenatal patients, wherever a cardiac arrest can take place. And in addition, you may have 2 clamps or ties, cord clamps. So it's not much, but then it has to be done at the place where you are doing the maternal resuscitation. That means no need to shift the patient to OT, no need to waste the time, no anesthetic. Only thing you call the neonatologist. And then you have to do it quickly, so and have a rapid access, so you can do it either by quick midline longitudinal incision and classical incision on the uterus. Otherwise, if you are not trained in that and you think you can quickly go through the transverse incision, you can even do a transverse incision. But the idea is to take out the baby within 5 minutes of the cardiac arrest. And then it is to be done even if it was also, another advantage of this could be it has no harm for the mothers, it is found. But there can be advantage to the fetus also of doing this within 5 minutes, because you may, in a salvageable fetus, you may even improve the survival of the fetus also. Now, as far as the consent is concerned, I think it is important that there is no need. It is done under the doctrine of the best interest of the patient. And once, suppose your patient, you've done this, another thing which is important is that your efforts of CPR should continue at the same time when you are doing this resuscitative hysterotomy, and you would only relieve your left the uterine lift at the time when you start doing this resuscitative hysterotomy. And another, what we need, suppose the patient has improved, she's come back as your patient, and then we can take this patient once the circulation is restored. So then you can shift this patient to the OT for closure. And otherwise, if suppose, and then you can, close the incision in situ, as you've already mentioned here in the slide. Suppose the patient doesn't respond and she dies. So then, of course, you have to look at the protocol of your hospital, whether she needs a postmortem examination. Then it's okay. Otherwise, if there is no postmortem, then you have to close this incision and present the body in a proper way. So all this while, a few more things which should be that somebody is briefing the relatives all the time what is happening. There is a timekeeper, because this has to be done within 5 minutes. And there's somebody who is documenting and maintaining all the notes. Now, having said that, it's seen that sometimes even slightly delayed resuscitative hysterotomy also helps improve the maternal survival. So people have done it even up to 15 minutes. So that is, but 5 minutes is definitely a better concept. That's the 5 minutes.
Thank you, ma'am. Thank you for such a nice explanation. And this is a concept which many of us are not really aware of. And we haven't read articles related to it. We have not seen anybody do it. And at our place, we did 2 such cases in last 6 months with help of Dr. Nalini. And so that's why I put this in the panel. And I could see some question in QA box also that there will be legal hassle and we should always take consent. So could you just make this point more clear?
So as I've already said that, this is one of the things which can be done under the doctrine. There is no need to have a consent written there in the best interest of the patient. So I don't think so. There would be a kind of, this would be because you don't want to waste time. So you can brief them later.
Yes, thanks for clarifying. And now this is the last question of the panel addressed to Dr. Shelly Arora. What should the communication to the relatives of such a case which Dr. Kiran just talked about? and what documentation should be done, and how should one prepare a maternity unit to effectively deal with maternal collapse?
Yes, yes, ma'am. My network is little unstable. I'm on my way, but I'll still try to answer all these three questions, like breaking the bad news, informing the relatives in these sudden rapid deterioration is very difficult. So the clinicians, as a clinician, we all need to develop those skills of communication to effectively explain that what happened. That will not only reduce the risk of having a medical legal litigations, but also will clear the doubts of the relatives and will give the closure to the relative as well. So few important points which need to be taken care while giving the breaking the bad news is like who should give this bad news, inform the relatives to, where it should be done and how. So I would say the treating doctor, the senior most treating doctor should be the one who should inform the relatives about the sequence of events, and it should be done in a very quiet place with minimum interruptions. Ideally, it is preferred that this doctor should be accompanied by another staff, which could be a junior doctor or a staff nurse or a colleague doctor. And now comes the most important part, how it has to be done. So we should always remember that both verbal and non-verbal communication plays a very important part in this. So non-verbal, we have to remember that we have to stay calm, with preferably seated and in an open posture, not having a crossed arm. It should be an open arm position and maintaining a eye contact. Lot of time we don't maintain a eye contact. It somehow gives the impression of that you're hiding something or you're guilty of something. So always maintain a eye contact. And while doing or speaking with a verbal communication, always remember to be honest, be empathetic, and be accurate of all the events what has happened. Try to use layman language and not medical jargons with the relatives, because it would be easier for them to understand. And since there's a lot of events and sequence of events which has happened, so give the information in chunks that what has happened, and always start explaining that what happened to the patient and how you deal with it, what all efforts and treatment we have given to the patient, and what is now the present outcome and what is the situation of the patient at present. And we can expect a range of emotions from the relatives. It could be complete silence, completely angry emotion, or crying also, knowing about their patient. So allow them to express their emotions. Once, after some time, start explaining and continue your explanation of the episodes. You might have to repeat your explanation again also, that how the situation of the patient is at present. More important is sometimes these patients, because of their emotions, can blame and do blame to the patient or to the doctor or to the hospital. So do not argue and do not respond rudely during these accusations. And do not blame any of your colleagues if you have received the call later on. And try to be supportive till the end. Like if the patient is transferred to the ICU, be there, any staff should be there when the relatives are accompanying and going to see the patient. Or if the patient is dead, then you have to be there while they see the diseased body. And we have to fill up all the incident forms and everything. Coming to after breaking this bad news, we have to remember that we have to document everything. Accurate documentation is also an incredible importance because of medical legal perspective. So ideally, like we have already been knowing that we should doing a simultaneous note keeping by a scribe about the resuscitation. But in emergency situation, many times this is not possible. So we should document in the file immediately as soon as possible, the retrospectively all the episodes which has happened. Documentation has to be done ideally with a black ink, because it is most legible when we photocopy the notes in the future. It should be written very clearly, no scribbling, no overwriting or cutting. Ensure that each sheet of the notes should have patient details, whether handwritten or a label is posted with the patient's full name, date of birth, or hospital unique identification number. Then we start mentioning about the sequence of event, what has happened, what time patient delivered, what symptoms she developed, which doctor reported, saw her first, then when did she call, who approached the second time. All this have to be documented with date and time. Lot of times a confusion is done because we are so hassled after handling this kind of a situation. So a lot of time we create problem with AM or PM time. So either use a 24-hour format or write properly AM or PM time. Then while, as ma'am has already explained, that we have to mention completely what all drugs and what all resuscitation procedures and fibrillation was done, defibrillation was used, or shock was given to the patient appropriately with exact date and time. And then the whole notes should be duly signed by the treating doctor or a physician with full name and her exact date and time. This is all about the documentation. Now, yes, it is rare to have a maternal collapse, but yes, we need to train ourselves, because most of these maternal collapse these females are young. They can be resuscitated well and they can actually be saved. So outcome of these maternal collapse, as throughout this whole panel discussion, has again and again imposed on the fact that an appropriate and prompt effective resuscitation is a key point. So all the caregivers should be skilled in starting initial effective resuscitation. All the caregivers should be aware of the common causes of maternal collapse so that they can actually treat and start investigation and treat the appropriate diagnosis and make the diagnosis. In rapidly deteriorating cases, what I find is that there is an urgent referral and escalation to critical care team. So every hospital should have a written protocol and a specified team of members for every code blue, which is being announced in the hospital. So a team is ready if any code blue is there. So people know that who have to reach that destination where this resuscitation is taking part. More important is annual and or either biannual formal simulated trainings, which can be done for these maternal collapse patient and obstetric emergencies. This should be done in a compulsory manner so that all caregivers are again and again get into form of become confident and have improved teamwork along with themselves. There should be regular mock drills can be conducted on a regular basis. We should also ensure the availability of crash cart at every department, at every important point, like in labor room, emergency department, in all the important wards, post-op, antenatal wards. So if any patient collapses, we don't waste time from bringing the crash cart from other places. And all the caregivers should be aware that where that crash cart kit is and how to use those equipment.
Thank you. Yeah, thank you, Dr. Shelley, for answering these questions so nicely. Particularly your points that you made about communication and documentation are very relevant. And an important point which Dr. Sangeeta Gupta has written in the chat box, also number the pages in the file in the correct order, because this you never know when this will become a medical legal document also. So proper documentation is very important. Now we come, I will just say the key points and we will close this session. Maternal collapse is often unpredictable, therefore timely recognition of a deteriorating patient is very important, and this can be done through early warning scores. We should make it a routine having these early warning score charts, and we should tune our residents to using them. And in West, it's the nurses who are doing this job. So whosoever is the primary caregiver in the wards should be aware of these scores, and they should be able to identify, okay, this patient is not good. Her scores are going into yellow or orange or red, and they need a higher level of care, or they need to be seen by somebody senior. Follow a systematic ABCD approach to assess and resuscitate, as Dr. Sangeeta Bhasin has explained it very nicely. Remember, after all the deliberation, we realized the key interventions are administer 100% oxygen, preferably via NRBM mask, IV fluids to be given after ensuring a large bore cannula, establish the IV site above the diaphragm, left uterine displacement of the uterus if patient is pregnant with more than 20-week size uterus, and this has to be done by one dedicated care provider. The previously, as we used to do wedges and tilts, they are found to be not as good as this left uterine displacement done manually. Manage the reversible causes. Once you have stabilized the patient a bit, look for the cause and manage the reversible one. Resuscitative interventions are concurrent, not sequential. You do everything together, not one after the other. High quality CPR and early defibrillation is needed if the patient has had a cardiac arrest. Next slide, please. Excellent team dynamics, clear allocation of roles, and closed loop communication is a key to success. Resuscitative hysterectomy or a perimortem cesarean delivery, it provides ultimate relief of aortic cable compression and is performed to optimize maternal outcome. Remember, if we have we get a live baby and an intact, neurological intact baby, that is like a good thing, but we are primarily not doing it to save the baby. We are doing it to save the mother. Ensure effective communication with the family, documentation and debriefing. Ensure preparedness of a maternity unit to effectively deal with maternal collapse, and training is very important. Simulation trainings, regular drills for managing maternal collapse, because this condition is so catastrophic, there is no time to think or recapitulate. It has to be there on the spinal level, not only at the cerebral level. With this, I will thank you all, the delegates, chairpersons, faculty, for your participation. Now I will request.
Ma'am, can I take few questions?
Okay, yeah.
Only one thing, acute atrial fibrillation in pregnancy not responding to cardioversion. And at 36 weeks of gestation, then how to proceed? Can Sonia ma'am take this question?
Yeah, normally for atrial fibrillation, either we can have the pharmacological or the electrical therapy. So cardioversion, normally even after the first dose, you can give another, repeat the dose. We normally start at about 100 joules. We can step it up to 150 also. And that is typically so if the patient is in a hemodynamically unstable condition for AF. And suppose the patient is getting pharmacological treatment, then of course adenosine is the preferred drug of choice, and which we can repeat. The first dose is 6 and then we can repeat up to 12.
Thank you, ma'am.
I will now request.
I can say that
And
any
also the
low
other
risk
thing, like,
patient-
sorry, just a minute, like Dr. Manoj said in his presentation, that if it's an acute AF, then we can give cardioversion. If it's a chronic AF and we don't know whether the patient has been on anticoagulants, then it is better not to give any shock at that time, because you can dislodge any thrombus and cause embolism. So there the pharmacological treatment, which are the 2 drugs, can be given. You can give a digoxin also at that time, because digoxin is a AV blocker, and otherwise the beta blocker metoprolol, which he had mentioned.
Thank you, ma'am. I can say that any low risk patient can become high risk at any particular point of time and can really give nightmare to any of the obstetricians. So resuscitating a critically sick patient is an art, and we should all familiarize with the steps. As an obstetrician community, we can say that together, that no woman should die while giving life in this world. With this, I conclude this session, and I'll just hand over to Dr. Deepika Jagsonpal team for a brief video.
Ma'am, this is not a video, just reminding everybody about 1 or 2 products of ours. Jagsonpal presents to you LycoRed, the only brand which contains 100% natural lycopene with phytonutrients, zinc and selenium also. Along with LycoRed, we also have LycoRed Preg sachet, which is L-arginine, DHA and lycopene to prevent pregnancy complications. We have Injection Maintain 250 and 500 mg hydroxyprogesterone caproate and EndoReg Dynamis 2 mg tablets for medical management of endometriosis. Thank you all so much for joining in today, all the attendees, and thank you all the faculty for giving in so much of time today and so much of knowledge that has been shared today. We invite you again for another webinar, which will be on progesterone, the wonder molecule. Progesterone recently launched by Jagsonpal. This is on Wednesday, 5 to 7 p.m. So do join us on the webinar ID mentioned. Thank you. Over to you, ma'am.
I will now request Dr. Nalini to deliver vote of thanks.
Thank you, ma'am.
Thank you, Dipti and Nalini, very nicely conducted. Thank you so much.
Thank you, ma'am.
Thank you.
The few people who made it all happen. It's time to say deliver vote of thanks, Dr. Nalini.
Yes, ma'am. Today I have the honor to be a part of RCOG, MAMC and NARCHI Obs Critical Care Workshop. And I would like to give my heartfelt thanks to our organizing chairperson, Dr. Asmita ma'am, Dr. Ranjana ma'am, and organizing secretary, Dr. Deepti ma'am, for giving this me wonderful opportunity to be part of such an important webinar with an aim to prevent maternal mortality. My sincere gratitude to all the learned stalwart speakers and all our esteemed faculty members, panelists, and highly experienced chairperson who took out their precious time from their busy schedule and to join us and share their valuable experiences. And special thanks to our multidisciplinary international faculty, Dr. Tasneem Pirani, Dr. Mohit Gupta, and Dr. Sonia ma'am for giving so much support, and in fact providing the videos by Dr. Sonia was really good, and they have created this academic feast a great event. I thank the sponsors of RCOG and NARCHI events for extending their valuable support. Beside extending gratitude to the team Jagsonpal, led by Dr. Deepika Chhabra, Mrs. Amit Saxena, and Mr. Ankit Dogra, giving this platform for their technical support and making it a successful program. At last, I thank all my audience to take out the time and attend, hopefully knowing what to do in scenarios which makes a difference and definitely going to reduce the maternal mortality. Thank you all. Happy learning.